to direct anyone to bathrooms. There we go. And you can hit the got it button. All right. I do not need to direct anyone to bathrooms since I have no clue where your individual restrooms, snack breaks, etc. are, which is one of the great advantages of the virtual world. So with all that, let's go ahead and get started with our introduction, which is being done jointly between myself and Maria Morgan. I've already introduced myself, and I'll let Maria introduce herself, and we'll get rolling. Thank you.
Good morning, everyone. My name is Maria Morgan, and I am a Master of Public Health student at the University of Wisconsin School of Medicine and Public Health, and I'm really excited to be joining the conversation today.
Great, thank you very much. If we could move to the next slide here, please, Rochelle. So, why are we here? What are we aiming to talk about? Very briefly, I will not do a dramatic read of all of these items, but we want to discuss what's going on in Wisconsin about this interesting overlap between the worlds of education and of medical care. We want to review and prioritize evidence-based school health and talking about all the different personnel that are engaged in thinking about the health and well-being of children in educational settings. We want to, of course, talk about the pandemic, and I want to highlight that our goal is not to only think about solutions and approaches and so on that are pandemic related, but to really think about how we can build better structures really for the next decade, 2 decades, et cetera, because I think there's a lot that could have been done even before the pandemic. And we need to consider, of course, mental health as part of that. And then thinking about how we can collectively use our voices for advocacy, align our resources, and come up with solutions that are data-driven. Next slide, please. And I will turn it over to Maria to set the stage.
So you may be wondering, why school health? Why is this topic what's bringing us together today? Well, I want us to think about a countdown, so to speak, of 5 pieces of information to consider. Next slide. So according to the CDC, schools have direct contact with more than 95% of our nation's young people. That's about 6 hours a day, up to 13 critical years of their development, which really indicates the scope of today's conversation. And in Wisconsin, we have almost 997,000 school-aged young people. And this is really telling us the scale of impact of today's conversation. Now, thinking of a health example of a concern before the COVID-19 pandemic that has affected both health and school for children is asthma. And we see in Wisconsin, 1 in 12 children have asthma. And among those, 41% have uncontrolled asthma. 1 in 3 are missing school in the last year. And now, as we face these challenges of the COVID-19 pandemic, we see during the week of September 12th this year that children were at the greatest age group of confirmed COVID-19 cases. So when we put the scale, scope, and health data that we saw with asthma and COVID-19, we see at the center is health and wellness for children. And even though we're coming with different backgrounds and different perspectives today, we share this common vision, and we're aiming for this better future and health of children. Which leads us to this project. As I mentioned in my introduction, I'm a Master of Public Health student, and one of the key components of our program is an applied practice experience. I was really lucky to get connected with the Wisconsin chapter of the AAP and Dr. Nazaria to really zoom in on this critical topic. As a Teacher America alumni and former elementary educator, I'm very passionate about learning more about how we can promote health in schools. And that helped us frame our project's focus, which was surrounding information gathering and decision-making surrounding health in K-12 Wisconsin school districts. And the project consisted of three key components. The first was a literature review. Then we conducted interviews with key stakeholders. And it brings us to today's interprofessional discussion. Now, many stakeholders have different priorities and different perspectives, and yet we are all going in the same direction of promoting health for children. The aim is to really come together, communicate, and find a way to work together in really promoting the health of children. Now, what may seem like a very overwhelming initial diagram is an example of a process map that helped frame the project. Center is that key topic of information gathering and decision-making surrounding health in our K-12 Wisconsin school districts. And as we see, there are layers of different influence here from local, community, state, and national levels. And this process map really helped us lead us to that literature review component. What we did is we took a systems thinking approach on the literature review. Next slide. And what we found was that evidence was spanning the different levels, things from national, state, community, and local. We found this bi-directional relationship of different examples of models that influenced how information is gathered and decisions are made surrounding health. One example of a model that spanned across these layers was the whole school, whole community, whole child model from the CDC. Now, this model is really intended to have a student-centered approach that offers emphasis on how the community's role can support schools in developing healthy models. And it also integrates this interconnection between health and academic achievement. And finally, it brings in this evidence-based policy and practices within the school. There was a variation across the states in how laws and application look, but we did see common trends. Access to healthy food during the school day, state level regulation on employee wellness, especially stress management. And also we found enacting policies such as trauma-informed practices with students. Now, this model, the whole school, whole community, whole child, is locally implemented, yet state laws and expectations do influence how the district policies affect. This profile for Wisconsin outlines the coverage of state statutes and regulations for specific topic areas of this model, especially these 10 components. And it really offers an opportunity for further consideration for how states like Wisconsin could approach these topics. The whole child approach is an opportunity for schools to promote mental, physical, emotional, and academic success for students. It's important to integrate the public support in order to promote healthy schools for all children. Based on a national survey of early childhood and K-12 public school parents, teachers, and administrators, there was support for a system-wide approach on the solutions. Now, a majority of the respondents believe that healthy schools could lead to realistic student outcomes. That includes school and learning engagement, preparedness for the real world, mental health with less anxiety and stress, and increased achievement academically. Yet further considerations such as barriers of teacher training, parental engagement, and school resources were noted. Healthy Schools Campaign shared in their recommendations for the next administration that the federal government must recognize the massive inequities that exist in school facilities and prioritize investments, especially in underserved communities. The Alliance for a Healthier Generation also mirrors efforts to really promote social justice, equity, and healthy children. Things such as community voices and elevating those voices, system-level change to really promote an equitable transformation, and also creating active partnerships for communities of high need. The CDC's Polaris policy process is another example of a systematic method to really address public health problems and concerns within the community. as we see central to the model is stakeholder engagement and education. And this really is a core component that led us to the stakeholder interviews. So during the summer, we conducted 27 interviews, and it incorporated levels of national, state, community, and local. Roles were ranging from school nursing, medical advising, school social work, public health nursing, professional associations, and other health-related organizations. And from these stakeholder interviews, several themes were gathered: information gathering surrounding health, decision-making, strengths and challenges, and the effects of COVID-19. Further, themes talking about the anticipated future were also gathered. Which brings us to this next component, our interprofessional discussion. Now, we're aiming to have us break out into small groups because there are so many diverse perspectives in the room today that we want to have an opportunity to come together and meet one another. So we're going to go into breakout sessions, and I invite everyone to take about 30 seconds to give a brief background, introduce yourself, tell a little bit about your professional background, and then take about 3 minutes to go through these 3 questions. The first being, what do you hope to gain from today's event? The second, what do you hope children will gain from today's conversation? And finally, what are tangible outcomes 1 year from now that could come from today's conversation? So again, we'll be going into breakout sessions, brief introductions, and then go through these 3 questions. The final piece is a survey form. We invite you to enter your responses to these 3 questions into the survey. We're aiming to visualize the results of your entries into word clouds, so please feel free to utilize short responses to help with the process of the word cloud later on today. So Rochelle, I would love it if you could help us break into sessions, and I will go ahead and enter the questions and the survey link into the chat, so that way everyone can see them once they're in their breakout. But before we go, does anyone have any questions as far as what to expect when you go into a breakout?
I think we're good. I'm not seeing anyone unmuting and nothing in the chat here. So again, brief introductions and then 3 minutes to discuss and then enter your responses into the survey link, which you will get in a few moments in the chat. And then we'll reconvene very quickly. This is a very short breakout. All right, you should see a join button appearing on your screen.
Just double checking, Michelle, were you able to see the chat feature come through?
Yes, I can see the chat coming through. It's just hard for, like, I'm in a full screen. It won't let me exit a full screen when I'm in presenter view for some reason.
Oh, no problem.
I
Just wanted to make sure that the link went through.
Yes, the link is through. When do you want me to close? I think
in 5 minutes.
Everybody's in there. Perfect. Things are good. So like what, you think 8:55?
Perfect. Thank you, Rochelle.
Yep.
Welcome back, everyone. As everyone comes back in from their breakout sessions, I invite anyone who hasn't had a chance to enter in the chat. You'll find a survey link. Again, we're asking that answers are short because we hope to compile those into a nice word cloud visualization. So feel free to take a look into your chat feature and select the survey link if you haven't already done so. Next slide, Rochelle. And I think we have a few minutes. If anyone has any questions or comments, feel free to enter those into the chat. And again, we'll give you all an opportunity to enter your responses in the survey for a few minutes. Dr. Nosvaria, anything else for this section before we move on to our next speaker?
I'll just say a couple of things. First of all, I just do, just so I don't forget this later, I want to thank Maria for her hard work in doing all of this. Our chapter is small and mighty. And sometimes we have the good fortune to find grant funding to be able to bring on personnel and staff to be able to make things, move along and so forth. This is one where there wasn't any obvious source of funding, but we felt it was really important. And Maria was really able to dig into the literature. And it's a wonderful example of how partnerships with training programs, and yes, I'm biased since I'm part of the MPH faculty, but it's a wonderful example of how we can combine education with work that does make a difference, that makes a meaningful difference in advancing human health. I'll also say that there are parallel threads going on out there. Maria also works with me on a similar project that is grant funded on the early childhood side. So we are actually about to launch a small pilot of doing health consultation in the 0 to 5 age space, where they look at K through 12 and say, wow, you guys at least have school nurses occasionally. That's amazing. We don't have any of that, right? So we are starting to build that out with the goal of going statewide as well. So these are being dealt with on many different levels out there. I know that I loved the conversation we had in our group, as brief as it was, to hear about people's hopes, desires, ideas. So please do fill out that link, because it'll help us not only collate things together in terms of your ideas, but also just give us all a chance to see what everyone else is thinking. Okay, and I see no questions popping up from here, so I will go ahead and move us on to the next section. Thank you again, Maria, and we will be hearing from you again later, of course, as well. So our next speaker is a dear friend, Dr. Jeff Lamont. He is also a former president of the Wisconsin chapter of the American Academy of Pediatrics, and is well known in the school health world, not just regionally, but nationally. He served on the Academy's Council on School Health, and really has been a lifetime advocate for thinking about the intersection between schools and health and well-being of children. Jeff, I'll let you introduce yourself further in any way that you feel is appropriate, and we look forward to your presentation, which will cover the relationships between school nurses and medical advisors.
Thank you very much, Dipesh. I have been in practice of general pediatrics since 1982. I serve as the medical advisor to a number of school districts in central Wisconsin, and I will get into that later in my talk. I do feel that as pediatricians, we do some of our very best work when we collaborate with other agencies, other organizations, and individuals who share our goal of, as a society, raising healthy, happy, and productive children. One of the ways in which that collaboration can be most tangible is through the school districts. And I'd like to discuss how a physician serving as a school district medical advisor serves as a flying buttress, as it were, for a school district health program. Next slide. Some statistics, just to give a perspective of how many children there are to be served in the United States, how many have a chronic illness or special health care need. Maria mentioned asthma, but you take into account allergies, various metabolic and other problems, and it's a significant minority of the children in school. And then how much time those children are spent in the care of school, remembering that schools serve in loco parentis, in place of the parent, when children are under their care. Next, please. This is significant. 10 to 25% of injuries to children occur while they're in school. I'll just mention, I know this looks old, it is old, but I had two medical librarians try to find more recent data. And in fact, this report in the MMWR is about the most recent of any comprehension to be available. Next, please. This is significant. And we'll talk about this in a minute. Part of it is because the school nurse operates so independently for such long periods of time. In some rural areas, a school may be a half hour from EMS basic level care. And in the meantime, it's the school nurse's show. Next, please. So given the likelihood that there is going to be a medical emergency occurring in school, the fact that this isn't in the upper 90s, and this isn't in the upper 90s is concerning. Next, please. So imagine that, suggesting that as a way to save money, the school football team not be allowed to practice or have uniforms or a field or a coaching staff, but could still play. Who would go with that? And that's for a game. Here you have children's lives at stake, and programs for school health get short shrift. Next, please. You will hear references made to Standard G. That refers to this G and Wisconsin statutes and Wisconsin administrative code. And they have to do with the provision of emergency nursing and medical services in school. There is also the Nurse Practice Act, Wisconsin Administrative Code N603, which pertains particularly with regard to duties and responsibilities that can and cannot be delegated by the school nurse, because any task that is delegated by the nurse is still under her license. And that is something that school administrators sometimes don't understand. Other laws to which schools are held, HIPAA and FERPA, and Louise Wilson of Department of Public Instruction will be addressing those briefly during her talk. Americans with Disabilities Act, Individuals with Disabilities Education Act, and of course, professional liability are all legal aspects of the provision of care, of which schools and physicians need to be aware. Next, please. So the provision of emergency nursing services in schools. Next. Notice each school district board, these are the people who are responsible, not the superintendent, not the principals, not the school nurse. Ultimately, it comes back to the school board. Shall provide emergency nursing services under a written policy adopted and implemented by the school district board, which means all of the following requirements. Next. be developed by a professional nurse or nurses in cooperation with other district personnel and representatives from community health agencies as may be designated by the Board of Education. Next. Protocols for dealing with student accidental injury, illness, and administration of medicine at all school-sponsored activities, including but not limited to curricular, co-curricular, and extracurricular activities, as well as providing a method for recording each incidence of service provided. Now, if you present this to most school boards, many of them are rather nonplussed at realizing just how broad the scope is of what the law says the school district is responsible for. Next, please. This is where the physician comes in. Arrangement shall be made with a licensed physician to serve as medical advisor for the emergency nursing services. Now, that doesn't necessarily go over into ADA or IDEA, but the fact is you're already hooked up for emergency nursing services. You would be the logical person as a physician to advise further. Next. Shall be available during regular school day and during all school-sponsored activities of pupils. Think of what that means in terms of interscholastic sports. Think of what that means in terms of late hours. You don't see the school nurse attending every one of these things, but some sort of provision of how we're going to handle this needs to be taken into account. Next, please. This shows that the legislation needs to be updated. The idea of having student administration or student emergency information cards as opposed to electronic records is rather 20th century. This is another issue. You would be surprised at what passes for space and equipment for school nursing services in some school districts. The idea that there's adequate space set aside with adequate equipment and facilities is more a dream than a reality. Next, please. And this, a review and evaluation by the school district board shall be made at least annually. That again doesn't happen, and I can say that from my experience serving on a local school board. Next. So, you're looking for a medical advisor, or you are a physician considering becoming a school district medical advisor. Well, it all goes back to the 5 A's, the things that they say should characterize any successful physician or any successful professional. Next, please. What you do is largely up to you. This is a matter of sitting down with the school district administration and deciding what is it that you will do. You may limit it to emergency nursing services, but if you're going to be comprehensive and if you're going to really provide what a school district needs, consider these. You would advise, how do I do things right? You would advocate for doing the right thing. You might find yourself, for example, serving on a curriculum committee for human growth and development. You may be asked to speak to how should a school district address LGBTQ issues. As I've said, collaboration, working with other professionals and community resources. Teaching, what is right? What is the right way to do something? Mediation. School districts, public school districts represent the community, and the community represents a wide range of opinions, some very strongly held, and your knowledge, your expertise as a physician may be key to making sure that the right decisions are made regarding providing for children and youth with special health care needs, other minority communities. It can come down to you. Never underestimate the impact that you as a physician can have in a community. When a physician shows up at a meeting, everybody takes notes because everybody sees physicians as being very busy with very important things. And the fact that your meeting drew a physician, that immediately elevates the importance of that meeting. And it makes everybody pay attention and look twice as to what was being discussed and why. Finally, you may be in a position to provide direct patient care. For this reason especially, it is important that a school district medical advisor maintain license and maintain liability insurance. If we go back up to collaboration, one of the things that we have done in central Wisconsin in the past 3 years is we have developed a group, the Central Wisconsin School Nurses. I believe that that group now has increased to about 20 school districts within Marathon County and surrounding. One of the things that you find with school districts is that they tend to operate as silos, and the nurses within those districts have little reason to consult or collaborate with colleagues even in adjoining school districts. We formed a rather informal group of nurses, and the first time we met, they looked around at each other and said, "Do you know, we've never met like this before." They went right from individual districts to the Wisconsin Association of School Nurses, but nothing in between. And now they have a forum. We meet once a month, but you can obviously communicate more frequently in between, but they have a forum. And when issues come up in one district, they have a means by which they can discuss those with colleagues. We have developed standardized medication administration authorization forms, standardized action plans for certain medical emergencies such as severe asthma, allergy, seizure disorder, and others. And this helps ensure consistency of care. It makes it easier when children transition from one school district to another because everyone is transmitting the same information in the same way. One of the things that we're working on now is a standardized reporting form for school district nursing activity. This makes it easier. If you recall the standard G saying at least an annual report, having such a form makes it easier to compile the information for such a report. It makes it easier to compare how the district is doing from semester to semester, from year to year, and it permits school districts to compare themselves one to another as to how much of something they're seeing, how are they addressing it, and so it helps improve consistency of care. Next, please. Ability will define and refine the scope of the physician advisor's role in the school district. bringing knowledge, experience, technical skill, you may find that there are certain aspects of the role that you are asked to play in a school district for which you do have to go back and study up a bit. The medical issues being dealt with in a school district can vary tremendously from year to year and even from semester to semester. You may go from having no diabetics in the district to having 3 just overnight. And the nurses have to deal with that. They may very well turn to you for help and assistance. You'll be working certainly in conjunction with the specialists addressing the child, but you may nevertheless be called upon to strengthen the connection between the child's clinical physicians and the school nursing staff. Next, please. This is key. You have to be approachable. What I can tell you about school nurses is they are used to operating on their own. They don't have learned colleagues at their elbow. They don't have administrative superiors who are medically knowledgeable. They will not call with trivia. They do not pester. They are used to solving problems on their own. They're like the nursing equivalent of a Marine recon unit. And being responsive, answering the phone, answering the email, and doing so promptly is absolutely key to strengthening this relationship. Next, please. And then be honest with yourself. Will you be available to do what they need? I can tell you that the more advanced planning you can do, setting aside a time, not just to address the crises that come up, but a time when you can talk to the school nurses about what should we plan for next year. This is one of the advantages of the Central Wisconsin School Nurses, is that it provides a time during which the school nurses can get together, talk, plan ahead. We had our meeting yesterday, and this came from the nurses. They are looking for a way to develop a document by which they can help train nurses' aides, the unlicensed assistive personnel, which are so key to providing medical care within the schools. But that's coming from the nurses, and that's going even beyond the COVID crisis to say, better days are coming, let's plan. And your being available as a school district medical advisor goes a long way toward making those plans a reality. Next, please. So, look at your scope of duties, look at the size of the district. How many children and youth with special health care needs are there in the district? What resources are available? And this last is key, and it is sobering. Support from school district administration and school board. I'm sorry to say that many people on school boards and in administration have little understanding, and as a result, little interest in nursing and medical issues within the school district. The reaction can range from disinterest to disdain until the wheels come off, and then they're reacting with distress and dismay. But it all comes back to the school nurse, because she's the only one who actually is within the district and has medical knowledge. And that nurse needs support from somebody. And that somebody may be from the specialist physician helping to deal with the child with a seizure disorder or with type 1 diabetes. But a lot of that support can come from the school district medical advisor. the independent, authoritative, knowledgeable voice from the community who can back up the nurse in terms of what she needs and that for which she's advocating. Next, please. And I absolutely mean what I said before. School nurses are the bravest of the brave. They can say what they will about ICU nurses, ER nurses, transport nurses. Nobody is braver than a school district nurse because those nurses work alone. They don't have backup. Access to EMS or clinic sites varies tremendously. You may be in a larger community in which paramedic level EMS is 5 minutes away, or you may be out in a rural district or EMT basic is a half hour away. And in the meantime, it is your show. And these nurses step up to that every single day. And again, your administrative superiors are often medically naive and have little interest. And this is where the school district medical advisor can step in and make a tremendous difference in how nursing services are perceived. Next, please. Affordability. It's a necessary topic just from the standpoint of a courtesy. It needs to be addressed, even if it's just to recognize that it's done as a volunteer, but it's a professional courtesy. Next, please. And finally, accountability. It's a component of all the other A's, but a school district medical advisor who will stand up for and beside school district nurses does a great deal to increase the nurses' effectiveness and to enhance their stature in the school district. Again, never underestimate the value of the medical degree. The fact that someone of your perceived stature is willing to get involved with the district, is saying to the community, this is important, you need to pay attention. That carries over into the work that the school district nurse does on a day-to-day basis. Next, please. So, when you are looking at Standard G and you are looking at what needs to go into it, when someone comes to you and says, how will you advise us on our emergency plan? Think of 5 Ps. Personnel, do you have enough staff? And again, that has to be enough nurses as well as unlicensed assistant personnel because there are limits to what can be delegated. You have to be able to help your nursing staff make others in the district understand where the limits are to delegation and care provided. Physical plant and provision of supplies. Do you have the space? Do you have the equipment? Do you have the facilities? That needs to come in some cases from you because you are independent of the district. You are not perceived as feathering your own nest. You're approaching it from the standpoint of this is what kids need. Plans and protocols. Think of football practice and then say, when was the last time you actually ran not just a code, but how you would manage a child with status epilepticus, status asthmaticus, anaphylaxis? When was the last time those protocols were updated? And then practice and playback. When you run those scenarios, is it just to be able to say you did it, or do you actually go back and look and say, what did we do right? What could we do better? And how do we improve? Next, please. And then your P's and Q's. How do you get what you want? How do you get what you need? You have to be patient. You have to be persistent. You have to be the one that doesn't go away. You have to be prepared, be preemptive, have your information ready to go, because the better prepared you are with an answer at the moment, the more likely it is that your point of view will be seen and you will have your way. Principled. What I mean by principled is putting it always in terms of the kids, never in terms of this would make life easier for the nurses. The focus staying on, if you can keep the focus on children, you make the people with whom you're talking or negotiating keep the same focus. And always be polite. That goes without saying, but some people have a way of getting passionate about things and losing their temper, and that's a great way to deflate an argument. And finally, be prudent, be politic. Your wishes, your concerns may be very important to you. The school board has to keep all of the needs of the district in mind. And so figuring out how you fit into all that and being willing to accept that is very important. Next, please. The cues. Keep in mind quality, just like with the forms that we've developed in central Wisconsin. It makes it easy for us to ensure a consistent level of quality. It helps us quantify what we're doing and make that reportable. Always be willing to question the process, be willing to question the status quo. Recognize that you may need to stand in line to be heard. Be quick with your responses, be quick with getting information back, and be willing to provide quotations, references, materials to back up what it is you're asking. Next. I just recommend this. This was developed by the US Navy. It's used in nursing situations in hospitals. I do recommend it as a way of communicating medical information. Report on a situation, what's happening now. Brief background, how did we get here? Give your assessment as a physician, as a school district nurse of what is going on. And finally, a recommendation or response, what you expect from somebody. Don't expect that people are going to draw the same conclusion about a situation that you did. Tell them what it is that you feel needs to be done and how they need to respond. Next. And when asking, be consistent. What I mean here is, if you ask someone to help with the PTA supper, you're likely to get, yeah. But if you say, can you bake me a pan of brownies for the PTA supper, you have narrowed and defined the task, you're far more likely to get an affirmative answer. So when you are making your recommendation, don't just say, I need help. Tell them exactly what you need and try to put it in terms of something that they would find difficult to refuse. Next, please. Politics is the art of the possible, the attainable, the art of the next best. And what COVID has taught us all is this next best can be a monster. It is sobering and astounding what different entities will settle for next best. It sometimes does not serve children in the best way. And that is why physicians need to be involved in the communities to make sure that the best opinion is included in whatever the community settles on as next best. Next. And again, all politics is local. It's fine to say that they're going to solve it in Washington, but they're not. What's actually going to happen to children, by and large, is going to happen at the state, the county, the school district level. And you need to be involved with those entities to make your voice heard in an impactful way. Next, please. This is Notre Dame, obviously before the fire, and these are flying buttresses. Next. Winston Churchill said to his wife that she was like a great pillar. She supported the church from the inside. Winston Churchill never went to church, but he supported the Church of England and likened himself to a flying buttress, supporting it from the outside. Next. So a flying buttress supports a structure from the outside, like half an arch. It cannot stand by itself, but when designed into the structure, both the buttress and the structure are strengthened. Likewise, the school district nurse and the school district medical advisor can strengthen each other in providing the best health care for your community's children. Next. I offer this only half tongue-in-cheek. We, the willing, led by the unknown, are doing the impossible for the ungrateful. We have done so much for so long with so little that we are now qualified to do anything with nothing. Next. Thanks very much. I hope this has helped. We do have the forms available. I didn't feel they needed to be reduced to a slide, but if you'll let us know if you'd like to see the forms that Central Wisconsin school nurses have developed, we'd be pleased to share them with you.
Dr. Lamont, thank you so much for your presentation. I will note that it's a delight to go between church architecture, the obligatory legendary pan of brownies reference. For those of you who do not know Dr. Lamont, it is basically a bingo card item for us when he brings up his pan of brownies anecdote. And what clearly you did not disclose in any conflict of interest statements, which was that the sponsorship, much like Sesame Street, by letters of the alphabet, the P's, the Q's, the A's in the mnemonic devices that you employed there. I wanted to start out with, so first of all, there's lots of love showing up in the chat with many thank yous and so on. So I just wanted to convey that. If folks have questions that they would like to put in the chat, please do, or just note that you'd like to unmute and ask a question in the chat, and we can do that as well. I will just start with more of a comment. You know, it's always been very telling to me that all these services in the legal code, which again is clearly in need of updating, but comes under emergency nursing services, right? Which kind of tells you a lot about how the what the viewpoint was, like that this should only be for emergencies, yet so much of what school nurses do is actually chronic care, right, of youth that need that care, and is so important. And I think it points to how the mindset has shifted so much over time, but that the language has not kept up with that.
Well, that's true, and one of the two things to keep in mind are that the technical advances continue, and you know, given the general principle that schools should be as inclusive and barrier-free as possible, the advances in technology make delivering that inclusive care more and more theoretically available. There are things happening in school districts now that could not have happened 10 and 15 years ago. But many of these children with chronic needs are walking close to the edge of medical fragility. And of course, if they go too far, then suddenly what was a chronic condition is now an acute emergency. So there is no oil and water separation of kids with problems and kids without that make the provision of emergency care and presumed to be episodic and infrequent. The fact of the matter is provision of such care is neither. And keep in mind too, that school nurses are held to the same care provision standard as would be true in a hospital. Nobody cuts the school nurse any slack for having to provide care out of a broom closet, for a kid with a trach. And the fact that there are nurses out there who can be handed that assignment and they nod and they say, we'll do it, and they do, is truly remarkable.
We do have a question from our amazing, able executive director of the chapter, Kia. Do you want to unmute and ask your question?
Sure. Jeff, first of all, thank you so much for your talk. And those of you who know me know that my passion for school health has been ignited by Jeff over the years. And so this has been a dream of ours for a long time to put this together. So thank you so much. I do have a question that's come up a few times, which is sort of talking about the range of engagement, appreciation, role, et cetera, et cetera. We do know that some medical advisors are compensated in one way or another, and some are not. And I'm curious about your thoughts on that, and whether or not that is an incentive for engagement by medical advisors, whether or not that's seen as a negative by school districts. I'm just curious if you could comment about compensation one way or the other.
Well, first of all, we want you to understand that if you're not being compensated as a medical advisor, that does not mean that you are decompensated. I think that I actually think that operating independent of compensation from a school district allows you to keep your independent voice. As I say, school district nurses do not pester. They do not come to you with trivia. And that's why I'm able to serve as the medical advisor for several school districts, because none of it is really taxing from a time standpoint. I think that it's something that, depending on how you're compensated by your clinic, it may be something that you say, I'm doing this in the community, and maybe your clinic has some formula by which they give you credit for that. But to maintain your independence as a voice, I guess I've just never felt real strongly about saying, well, I can do that. If you come to an understanding with the school district, and the school district treat you become then an employee, as it were, or an independent contractor, that's a different realm. Hello, Louise.
Yeah, that's it's an interesting question. You could also argue on the flip side that organizations, school districts are no different, value what they pay for, and might be more likely to loop you in or ask questions or consult. I don't think there's an easy, obviously correct answer to that. There are definitely pros and cons on both sides.
I agree. Free advice is worth every penny in some people's minds, and but again, maintaining the independence, however you choose to do that. Remember that the school district medical advisor serves at the school district's pleasure.
Mhm.
You know, and again, maintaining the independence, and particularly maintaining it is, I'm here because the kids sent me. You know, it sounds all altruistic and everything, but when you look at what school district teachers and nurses give of themselves with no compensation for the sake of kids, you know, so in that sense, an example for the community that's rather noble. I'm overstaying my welcome here.
Thank you so much, Dr. Lamont. Again, really appreciated, wonderful insights. I'm pleased to introduce our next speaker briefly. So when you talk to just about anyone in Wisconsin and say the phrase school nurse, they say, have you talked to Louise Wilson? And we say, yes, we have talked to her plenty. And it's amazing how much she knows on this topic and how many people and situations and advice and history and all the things she brings to it. She's a school nurse consultant at the Wisconsin Department of Public Instruction. I will let her add any other words of introduction, but Louise, please take it away, and thank you again.
All right, well, thanks for having me here, and really appreciate it. And I see that I have several of my school nurse colleagues in attendance, so I'm glad that they were able to join in and to be part of the discussion and hear the great things that Dr. Lamont always has to share about school nurses. He really has been. I've been in school nursing for about 28 years, and he has always been a strong advocate, so that tells you a little bit about both his and my age too. But has always been a strong advocate for school nurses, and have been very much appreciated about that. And I'm glad that also that you were able to have this and organize this, Maria. I labeled or titled my presentation "Supporting School Nurses Who Support Students," and would just kind of go off of what Dr. Lamont had said about that the greatest role, really, I think that medical providers can provide for districts, and that is to help support the role of the school nurse and what the school nurse may be recommending, and just really the role of school health services. So let's see, I didn't know if you were doing this for credit, so I just have to put a disclaimer, and then again, I don't have any conflicts of interest, so in case you are getting CMA for this. Okay, so these are the things that I'm hoping to do in the next half hour here, is to provide some context to school health services delivery in Wisconsin for those of you that either might be considering becoming medical advisors or just want to really know about more about student health services. I'm going to describe my role at DPI in supporting that, kind of review some health information and the sharing of health information between schools and healthcare providers, HIPAA and FERPA, explain the use of standing orders and protocols in schools, describe nursing delegation issues and how medical advisors can kind of help with that, share some information on some DPI resources for medical advisors. We do have some job descriptions. And then I know that this afternoon or a little bit later, you're going to be talking with a panel to figure out what you can do to improve students' physical and mental health. So I'm going to give you some ideas to think about for that future discussion today. So here is data from the third Friday count of last school year. So on the third Friday of when the school district year starts, so it's usually a Friday in September, school districts have to report to DPI how many students they have, what kind of staff they have. So in Wisconsin, we say that there's 421 public school districts, and of that, 315 of them did report that they had had some kind of school nurse. That meant that 106 did not. So, you know, that's a significant number. So almost a quarter of school districts do not have a school nurse. A large number of students there, over 800,000. And there's 464.7 school nurse FTEs. So of those FTEs, 139 reported having less than 1 FTE of nursing services. Some of those nursing services might be reported as 0.001 FTE. So I think that comes out to be about 10 hours a month or 10 hours a semester. At one point, I figured out that. So they would say that they have a school nurse, but that school nurse shows up or does something for them 10 hours a semester or 10 hours a month. And then 176 school districts have at least 1 full-time FTE. Doesn't mean that they have 1 nurse that works full-time, and they might have 2 nurses who work part-time. Again, using all that, we estimate, or last year estimated, that there's about 610 school nurses serving public school districts. So again, the median ratio for a school nurse to students is about 1 to 1,400 if you have a school district. So that would be within those 315 school districts that have that. So that's kind of the landscape of what we're looking at. And when Dr. Lamont was saying that, you know, school nurses often practice independently, they're by themselves, the data shows that. So what do I do to support school nurses? Or what does the Department of Public Instruction have? First of all, they have me. So I'm the state school nurse / health services consultant is kind of what I call myself. And so my position is full-time. We do have 3 other pupil services consultants. So there is a school social work consultant, a school counselor consultant, and a school psychologist consultant. And DPI pays our salary. And really what my role is to provide resources, information, help school nurses problem solve, but I also provide that same support to superintendents, other school district staff, to other organizations, to parents who contact me and need resources. So that's one of the things we do. We have several web pages. And that is the link at the bottom, and I can also share my slides, so if people are interested in that link. But that is the web page link to kind of get you started. There are several different web pages and resources that we have. Do provide guidance documents. So the Department of Public Instruction has several guidance documents, many school health services specific, but some regarding record confidentiality, bullying, mental health resources. So there's lots of documents. Also, DPI hosts a new school nurse orientation every year. So actually, that school nurse orientation is tomorrow and Friday. So it's a 2-day orientation. Generally, we do it in person. For the last 2 years, including this year, we are doing it virtually. I actually have over 150 school nurses signed up to do it. It's free, so you know people can readily attend. But of that 150, I was looking at the registration. I think there's less than 10 that have said that they actually have been a school nurse longer than 3 years. So we've kind of left it open because I don't really have to set a limit. So there's a significant number of school districts that either have had turnover or have hired school nurses, and you can imagine some of that is in response to their needs because of COVID. But I think also that school districts are starting to appreciate what school nurses and school nursing services can do for them and for the children in their district. And as Dr. Lamont hinted at, and we'll talk about it a little bit more, the increase in the number of students with chronic health conditions and the impact that has on schools. And then we also host school nurse network meetings. So once a month, I have kind of an informal school nurse network meeting. We had one yesterday. Usually I share a little bit of information about what's happening, what might be current things to be looking for. People can ask me questions if they have some specific questions. Of course, school nurses contact me via phone or email all the time. And then we break out sessions so that the school nurses really can network and share. And I think that a lot of times they find that that's the most important, because again, they're practicing independently, and it's good to talk to another school nurse who's might be going through the same issues. and that just to feel that they're not alone. And also, we have school nurses from all over the state who attend those meetings. So it's interesting to hear what other parts of the state are doing, because people practice and have different situations and different parameters that they're expected to practice in depending on where you are in the state. I also have a school nurse listserv that I keep. That listserv, the participants has grown enormously since COVID, because we advertise that as, if you want to hear the latest about what's happening with COVID, subscribe to that, because I was sending out 2 or 3 emails a day sometimes in the spring of 2020. So we do have school district administrators, allied health personnel secretaries who are serving as their health person for their school district, also subscribe to that. But I send out information via that listserv. If anybody wants to be on that listserv, you can send me an email and I can sign you up for that. And then also via that listserv, I also publish a bi-monthly or every other week newsletter for school nurses. So those are kind of the support things that DPI and what I can provide for school nurses. And again, if you're interested as a physician, I know the school nurses, they're on, I have accessed all of those resources, but if you and a few of them are helping me tomorrow with or on Friday with the school nurse orientation. But if you would like to subscribe, please again contact me. So I want to talk just a little bit about the sharing of health information, because I think this gets confusing, or obviously for clinics and medical personnel, but it also is confusing for school nurses. Because again, many school nurses come to school nursing having practiced in the healthcare settings. And so they're familiar with HIPAA rules and not FERPA laws. And so FERPA stands for the Family Education Rights and Privacy Act. And so that really is everything that has to do with school records. So anything that is created as a record, it can be written, it can be electronic, it can actually even be verbal, it can be videos. So if you're, videoing what's going on in the lunchroom to make sure that people aren't goofing around, or you can, identify who started the fight, that all becomes a pupil record. So everything that school nurses do, everything that they write, really, and everything that they touch is really related to FERPA. So they have to understand FERPA laws. It helps to understand a little bit about HIPAA laws, but really school nurses are not HIPAA bound. Obviously, when we talk about getting information from a clinic or a doctor or post-discharge notes from a hospital setting, we're talking about needing to interact with HIPAA. And, as you know, the HIPAA Health Insurance Affordability Act. But HIPAA relates to those entities that are actually healthcare facilities. And school districts are not considered healthcare facilities. Yes, school nurses are healthcare professionals. And so a document that they create becomes a special kind of school record protected by HIPAA. Protected by FERPA and has some extra confidentiality, but it's not a HIPAA record. So none of the records that school districts keep on students are responsible or applied to HIPAA. But both sets of laws do allow sharing of information. So from a FERPA standpoint, FERPA is actually more restrictive than HIPAA is as far as sharing healthcare information. And I think most medical providers would kind of disagree or not understand that. But and so I'll start with HIPAA. So HIPAA does allow a physician or a nurse that is contacted at a clinic to share information with the school nurse, who is another healthcare provider, as you know, because HIPAA does allow the sharing of personal identifiable health information without consent. And this is, I should preface this that I'm talking about without consent. So we all know that if we have parent permission from a school record standpoint, or we have parent permission or student patient permission to share information with another entity, it doesn't really, the acts don't really matter. It's when we're kind of sharing that information and we didn't get specific information to talk to that nurse at this time, or we need to share some information and kind of quickly. So again, from a HIPAA standpoint, doctors can talk to nurses, nurses can talk to doctors, doctors can talk to each other if they need to, because they're both involved in that particular parent or patient's treatment. So a physician can call and ask a school nurse, and clarify medical orders and share some information about treatment records. On the same standpoint, FERPA allows a school nurse to call a physician and clarify what a medical order is. So if a school nurse receives an order for doses of medication and it seems either excessive or not enough, or the student is not responding to it, or they really want to let the physician know, I know we've received this order, but I need to share with you that the student has gone for 2 weeks without medication. And I called the pharmacy and have found out that the script's been filled. And so I need to share that information with you. That we're not getting it, what would you like us to do? Or here's an order, this medication's not working, we're not seeing the side effect. A school nurse can share that information without parent permission, and the physician or prescriber can, or any medical provider can share information. I always tell school nurses, because FERPA is actually a little bit more restrictive, because what FERPA would say is if you're talking about patient and it's kind of considered an emergency, or you need to clarify orders. So school nurses can, I always tell them, you can listen more rather than share information. So what would be considered a pupil record would be what classes the student's attending, or how many days they're showing up. So an attendance record is a FERPA protected record. So technically a school nurse cannot go out and share without parent permission to tell the physician that the students only showed up for 30 days of school and we've already had 100 days of school. So the school nurse can't offer that information. They could call and say, just want to clarify this order. You said that you saw the student and that they should be excused. I just want to make sure that that's really concerned. Again, the physician could go on and say, yeah, well, they came to my office and they say that they haven't missed any school. And so the physician again can share some of that information because they're again working with the student, but the school nurse has to be careful what they share. So again, there can be some sharing of information. And again, I can share these slides, some documents if you're saying, I'm not really sure that Louise understands that, or I'm not really sure that's true. Here's some documents you can read to say that, yes, it is, you can. And again, that's kind of without patient permission. If you have parent permission, which is always what I recommend, is that school nurses work with the parent. Again, if you can be that trusted healthcare professional, school nurses, I always tell them, are ultimately confidential. I know, unfortunately, that same level of confidentiality doesn't translate to other school professionals. But I tell them, school nurses, by their nature and by their education and by their ethics, basically the Nurse Practice Act talks about it, are extremely confidential. So if you allow the school nurse to have some contact with that medical provider, I can guarantee you that they will filter it, only share the information that needs to be shared with school staff, because that's the other part of FERPA, is that you can share health information with other school staff on a need-to-know basis. But school nurses are very good about determining, the teacher doesn't really need to know that, nor does the principal necessarily need to know that. I just want to mention a little bit about standing orders and protocols. So as a medical advisor, you might be asked to help develop protocols or write some standing orders, as Dr. Lamont kind of mentioned. Most common ones that you might be asked to write is over-the-counter medications administered by licensed school staff. So, so this is kind of an interesting, I wouldn't say dilemma, but interesting situation is that there is a state medication law that allows school district staff, if they're appropriately trained and authorized in writing by a school district administrator, to administer medications to students. They don't have to be trained if they're giving oral pills, because the state legislator figured it was a no-brainer to hand out pills, even though we advocated as school nurse organizations that, you know, the pills we hand out can be dangerous, and if given to the wrong student could actually, you know, be lethal. But the late legislators determined that oral medications didn't need to be trained. But if you're going to give a medication either rectally inhaled by the student, injected into the student, or given through a tube like a gastrostomy geodospy tube, then people do have to receive specific training. But what happens is, and then they just need to have a note for like, particularly from over-the-counter medication, they just need to have a written permission from the parent. As Dr. Lamont mentioned, there's consortium have really tried to make that note standardized so that everybody is using the same note, and that's helpful. If it's a prescription medication, there also has to be obviously a medical order, and again, that helps if everybody's using kind of the same form. But over-the-counter medication, any medication, if you're either a registered nurse or a licensed practical nurse, you also need to have a medical order. So oftentimes you might be asked to write an order that just says, if the student has some over-the-counter medication that the parent has authorized, the LPN or RN can also administer that. Very interesting in the fact that, again, I would have a medical order to give the Adderall because that had to have parent permission and a written order. But if a parent wanted me to give a student some Tylenol because they're having a headache, if I was the one who was going to be there and be able to administer to that student, I couldn't do that unless I had this protocol. So again, that might be a common protocol or standing order. Oftentimes you will be asked to write standing orders for stocking of medication. And again, sometimes that might be emergency medications as listed below there, epinephrine, Narcan, or albuterol. It also might be over-the-counter medication. Some school districts will stock things like ibuprofen or Tylenol, or maybe Benadryl or Neosporin ointment, or some other common over-the-counter medications. And again, you would be helpful in determining what those medications might be, and then writing some protocols and how to give that, and then maybe a standing order that the registered nurse or the licensed practical nurse could also administer those medications. Again, the state medication law is silent on the stocking of medications, except it does specifically talk about emergency epinephrine. And there is a statute that's going through that talks about not only auto injectors, because right now the law says auto injectors, but they're also adding pre-filled syringes of epinephrine to the state law. So that'll probably be passed. And then also just some basic first aid protocols. Again, lots of times if it's this lone school nurse who is looking at writing these protocols, it's also very helpful to be able to share those protocols with someone who has the medical knowledge and eyes that can look at this and say, yeah, this is practical. This seems what this school district is able to provide this level of care, and these are reasonable. So that might be, again, something that you might be involved with. And then also communicable disease protocols, which have become the bane. And I'm not going to talk really about COVID specific, because your minds can all go there with what your duties might be with that. But that is another area that medical advisors are very much involved in, and it is helpful to get that information. So I just also want to talk a little bit about delegation in schools. And so here's 2 documents. If you want some more information, there's a document that's pictured here, and then also have about a 20-25 minute module that goes through PowerPoint kind of module that talks about delegation in school nursing. So, whoops, I want to go back. So I just wanted to mention, why delegation is really complicated in school. It's because there's the school administrators view of delegation, which means you just assign somebody to do something and they do it. And then the school nurses view of delegation, and which obviously is very different. So it's a professional responsibility, there's professional standards, there's legal implications, and it also often feels like school nurses are having to remind school administrators of these obligations and of this law. And as again, Dr. Lamont mentioned, most often school nurses are supervised by people who have no medical or nursing knowledge. There are some school nurses, and I think we have one on this meeting who is a school nurse supervisor. Linda, I'm just going to call you out there. And so she would supervise a group of nurses. So those nurses are fortunate that when they say they have a problem, Linda is able to look at it from a nursing lens and help them problem solve that. But then again, Linda is probably supervised and reports to someone, again, who has no knowledge of school nursing. And they also need to keep reminding school administrators that that only that RNs can delegate, that LPNs cannot delegate nursing procedures. It says in the Nurse Practice Act that it is the purview and it's the responsibility of registered professional nurses to delegate care to LPNs and less skilled assistants. Yeah. So again, these are all the different applicable laws that school districts have to apply in delegation. And Jeff had mentioned the standard G. There's several parts of the Nurse Practice Act that get involved. And then there's also special education and 504 American with Disabilities laws that also need to be considered when doing and applying and determining who can be delegated to and what procedures can be delegated to. So how a medical advisor can help with that is that you can just simply affirm to the school board or to the superintendent or to the principal that there are some standards. Yes, the school nurse is not crazy when he or she tells you that there are some rules that need to be followed, and know that that will not be a good procedure to delegate. Providing some medical context to why the school nurse is saying or he's saying, yeah, I cannot delegate trach care, or I cannot delegate taking care of a student who has a ventilator at school to the secretary who's going to be trained. I cannot do that. This is a procedure that's very complicated. There's a lot of things that could go wrong. There's a lot of assessments. And that's one of the main things that school nurses have to grapple with is that you cannot delegate or give away that implementation of a care if there's going to be nursing judgments, critical assessment piece that can only be done by a registered nurse. And then just supporting that there needs to be medical orders. I think Jeff mentioned a little bit about the role medical advisors might play in special education law, the IDA, and sometimes school students need to have medical procedures done, but the parents aren't providing the medical orders. And so just reinforcing and maybe helping negotiate and maybe helping talk to the medical provider of the student that's being involved in the IEP to let them know that, yes, we do need to have medical orders. And again, just supporting the school nurses' view and that this is a requirement. And then also just, I think, reminding colleagues and pointing out to them, as one of my first slides said, is that it may not be a registered nurse carrying out those medical orders. I think that is becoming common knowledge now, but I can't tell you the number of times in my practice that, orders were written and they, it was assumed that I, as the registered nurse, they knew that our district had a nurse, that I would be doing the procedure. That often is not the case. So again, just kind of communicating and sharing that with your colleagues would be helpful. supporting of that. So Dr. Lamont again talked about a little bit about a medical advisor and what your job description is. So I just want to let you know that we do have a sample job description on our website. Here it does list some of the possible duties that you might be doing, the time commitment, if you're going to have a job description or a memo of an understanding or some kind of contract, that the time constraint, the compensation, as you kind of alluded to, any equipment that you're going to be needing, and legal issues, you know, if you should have your own malpractice insurance, and that all of those things might be addressed in the memo of understanding. And again, we have a sample on our website for you to do. And then I just wanted to kind of set you up for what you're going to be talking about afterwards, about not only the physical health needs of students, but the mental health and behavioral wellness of students. And just to share with you that the National Association of School Nurses actually has this very well-written position document. And their position is that student behavioral health and wellness must be prioritized for students to successfully access and engage in educational opportunities. It is imperative that school systems respond to and address student behavioral health and wellness to ameliorate disparities related to the social determinants of health. And school nurses are often the initial access point to identify concerns, determine interventions, and link families to services. And so I'm sure that doesn't surprise any of those listening to this webinar right now, or this session, but I think that that's important to really understand that oftentimes school nurses are involved in mental health. They're the access point, but given all the other responsibilities, we don't often get to spend a lot of time following up with students. And so what I wanted to just again point out that this is just a shared responsibility, not only amongst school nurses and the other people in the school, as I mentioned, the school counselors, school social workers, and school psychologists, but it's also very important that we have community members. So I wanted to point this out. I don't know if you all are aware of this. I think I mentioned this in a school nurse newsletter a few weeks ago, but there's a new consensus statement that is written about the core tenets of chronic health condition management in schools. And again, there's a link to that, and you will see that the American Academy of Pediatrics was very much involved with that. And I just wanted to kind of point out a few things that they talk about the core tenets and some foundational supports that are needed and are intended to address collaborative by school stakeholders. And school stakeholders are defined by those that have worked directly with children in schools, and then also community partners, and you would see yourselves there as community partners. And rather than setting forth an entirely new model, this consensus statement used and drew from previous models already in use by school stakeholders. So those are the stakeholders that are kind of identified that might be working with chronic health condition and condition management. Here's the core tenet. Whoops. Through that, here's some of the core tenets of that are addressed in there: accessible, comprehensive, coordinated, culturally effective, evidence-based, child and family centered. And so again, just kind of think about those as you talk later. And then foundational supports, supportive leadership and organizational cultural. Again, how can you as a medical advisor help with that? Dr. Lamont again talked about some of those issues: information and communications systems, and then again the sustainable and equitable funding. And you know, just how did the document itself really talks about how to get started and really convening stakeholders. So even a webinar like today, convening some stakeholders of school nurses and people who are medical advisors or who might be listening, who might be potential medical advisors is a start. Identifying the strengths and gaps in what's happening in a particular school district, and then developing collective goals and strategies to address those gaps. Because again, as Dr. Lamont alluded to, the laws were written to address emergency nursing services. And it's interesting. Actually, there's 3 laws that are written about school nursing services, emergency nursing services in Wisconsin. The first one just says what he had said, provide emergency nursing services. The second one says school boards need to make sure that there's a first aid kit in the district. That's it. That's the whole law. And then the other one goes on and details a little bit more, but that was pretty skimpy. And it really just says that you need to, again, as he mentioned, provide for medication administration, provide for injury and illness. And it doesn't talk about this whole big role of students who have mental health needs that lots of people, we need lots of resources to address. It doesn't talk about the chronic physical health needs that, again, falls primarily on the responsibility of very stretched school nurses. And so we really need to think about a kind of a collaborative and a comprehensive way of doing that. And I know that that's going to be some of the information that you guys are going to be pondering with and thinking about. So here's my contact information too. And when you get the slides, we'll have that. So I think I'm just at my time or maybe a minute over. So I don't know if there's any questions. Otherwise, I will end my presentation. Thanks.
Thank you very much, Louise. As always, you are a font of information and knowledge and connections and perspective and advice. It's so deeply appreciated. Let me take a moment here and see if there are any questions. Please, as always, please put them in the chat or indicate in the chat that you'd like to unmute. And of course, our presenters are generally kindly introducing and offering their contact information. So if something occurs to you later, that they will be able to, that you will be able to get in touch with them. Because we all know sometimes it's a few hours later that you suddenly realize, wait, I should have asked about what X or Y.
This is Kia. I just want to thank Louise personally. Again, I know all of us do thank you, but I've seen Louise in action on many fronts, and nowhere, to use Jeff's terminology, were miracles performed than when the pandemic first started, and all the school nurses, suddenly school boards were like, oh, okay, you guys are the people who know about healthcare. So can you just tell us now what we should do? And the way Louise handled that and sort of said, don't worry, we're going to have a weekly webinar, we're going to provide supports, we're going to figure this out, was just nothing short of amazing. And I think all of your school nurses just appreciate, it's clear how much they appreciate your support and just single-handed advocacy for all of them. So I just really appreciate that. And I know they do too. So thank you.
Thank you. I do see that there's a question about LPNs or NAs, school nurses, RNs. So to be a school nurse in Wisconsin, by definition, you have to be a registered nurse. LPNs can work, they can't call themselves a school nurse, but LPNs, or you could have nursing assistants and certified medical assistants, helping. But oftentimes the people that are helping are really secretaries and teacher aides and the janitor. There are a few nurse practitioners who do go into school nursing. It used to be many years ago that Madison, as you can imagine, being well-resourced, had a lot of their school nurses were nurse practitioners. That is not necessarily the case presently. Again, and one of the issues is that you need to, as I tell people, you need to pay nurses for what they are, and school nurses can get jobs other places. Teachers have to go to another school district who also is paying them poorly, but school nurses can, and in particular nurse practitioners, can go someplace else. And not that any healthcare workers are is a lucrative business, but working in a hospital, you can probably make more money than you can in most school districts. So pay them what they're worth.
It's interesting. I was reading a recent article that was talking about how within health systems, wages have not risen for healthcare professionals, whether it's physicians, nurses, OTs, PTs, at the same rate as they have for, say, cafeteria staff or cleaning staff and so on, because there's so many other venues in which they can apply their background and experience. So interesting to think about that in a school perspective. There's also a question about, do private and parochial schools fall under the guidelines from the state of Wisconsin for school nurses?
In most aspects, yes. As far as needing to have medication laws, they should be providing for emergency nursing services. Obviously, a registered nurse is a registered nurse, and so he or she, their practice falls on the Nurse Practice Act. Doesn't matter if they're practicing in a private school, public school, or as Jeff mentioned, doesn't matter if you're in an ICU, you still have the same standards. And you can imagine trying to do some of the same procedures that might be happening in an emergency room that you're doing also on a daily basis in a school is different, but you still have the same standards. So yes, so generally they do. DPI, well, DPI really doesn't, and I see a former colleague, Monica Caldwell there, so she know, hi there, Monica, good to see you. Knows DPI really doesn't have much authority over even public schools, so we provide a lot of recommendations and information, and I think that's becoming known a lot because of COVID, but maybe you didn't know that. So I don't oversee school nurses. The state superintendent doesn't oversee schools. We provide a lot of best practices, but best practices are best practices for public and private, but no one really has to follow our advice either. So I'm in the same boat of being frustrated by, I've got great ideas and good things, but no one wants to listen to me anymore. So I appreciate being here today.
Well, we all value and want to listen to you. So hopefully we can make things happen.
Yeah.
Well, thank you again so much, Louise. I think, one of the challenges of the Zoom era, of course, is the fatigue of sitting in front of your computer all day. So we will take a break at this moment. I'm sorry, Sean, I'm sorry, I just saw you use the hand raise function there. If you want to ask your question real quick.
Yeah, if I could sneak one in, I would really love that. Thank you so much, Louise and Dr. Lamont. I think given the limitations that you're just describing around DPI not being able to mandate or require certain, practices or policies around school nurses, I'm just wondering if in terms of like best practices or what we can learn in terms of school districts that have created policies on their own or really invested, I guess, in school health and school nursing. What I heard from Dr. Lamont's presentation, of course, was a really important lever in improving school health is having that strong, trusting relationship with the medical advisor. What I'm hearing from you is, of course, like school nurses, and what I know from other conversations we have is school nurses have been required to do so much in the last year, and we're being, asked of a lot before then. And sort of wondering how, given that I think that schools and school superintendents and communities are now more than ever noticing how important health and wellness needs to be and prioritizing the school setting. I'm just wondering how we might use this opportunity, like a little bit more visibility to try to advocate for better school nursing coverage or just more investment. And just wondering if there are any success stories here in Wisconsin or in other states that you know of like great work in terms of investing in school nurses.
Yeah, so I will just briefly, not to hold you because everybody does need to take a little break. Two things at this moment. So two things. One is that the Department of Health Services does have a grant. It's from the Affordable or whatever one, the ACA things, that they have 1.8 million that they are going to be given to invest in school health. So I've advised them on some ideas that I think that they can use. So there is that money coming, and so I think that might help. The other thing is that I would say, because of everything that's going on with COVID, and I think the school nurses would attest that last year school nurses were the heroes. This year they're becoming kind of the villains, and so I would stay away from talking about school nurses from the communicable disease standpoint. And my advice is that we need to go back to saying, what it is, the other things that school nurses do, providing chronic disease management, and that, if we work with not only just the medical advisor, but with the physician who's or nurse practitioner who's taking care of that student, together we can really manage it, because the school nurse has got them, for 6 days a day. They know if they're managing their diabetes, if they're really following that, they can implement the plan for the seizures, all those type of things. They can talk to the student how it, feels like to live with knowing that you have seizures or asthma or whatever. So I think I would emphasize those things. So that would be my recommendation, is to emphasize the other part of really what school nursing is about. Yes, we were heroes because we're the only people that understood COVID and what needed to be done. But I wouldn't emphasize that as much this year at this point, and I would emphasize the others.
Great. Thank you so much for both the question and the answer. So one of my proudest achievements during the pandemic is recognizing that there is such a condition as Zoom-induced psychosis caused by sitting in front of Zoom for far too long. So let's take about a 10-minute break here. Please go off video, go off of audio, get up, stretch, move around a little bit, and then we'll start again at just after 10:35. Thank you so much for everyone who's here. I know that people are taking time out of their days and popping in and out as their other responsibilities do press on them. We do appreciate you being here, or if you're watching on the recording later, we appreciate your interest in this topic and are so glad for that. Just as a reminder, we did have that survey we did early of your kind of thoughts and hopes for today. Maria is going to repost that link one final time. Please fill it out if you haven't already. It's a few simple questions so we can get some feedback and also generate some word cloud graphics from that. So if you could do so in the next 5 to 10 minutes, that would be greatly appreciated. I'm pleased to move on to our next presentation of the morning. We are going to spend a few moments talking about mental health, right, which is sometimes strangely dissociated from how we talk about health and all in our system. Yet it is so critical and so important and such a major part of what we've all been coping with over the last couple of years, and chronically before that, of course. We are thrilled to have Monica Caldwell joining us, who I will let her introduce herself and her work and her background, although I will only point out that she is, of course, setting a very poor example by being willing to join us while she's on vacation. Monica, thank you so much for doing so. We so look forward to what you have to share. Thanks.
Well, thank you so much. I'm happy to be here. And yes, I am in Sister Bay in Door County in a public library where I rented out the community room to hang out with you guys. This is beautiful. It brings a tear to my eye. I am a big believer in collaboration in all forms. So when invited to hang out and grow and think about the children that we care about, that we have in common, I'm likely to say yes to that kind of request. So happy to be here. And just by way of introduction, just very briefly, I am celebrating 35 years of social work practice this year. What? How did I get here? So it's so amazing to be, to have found a profession that fits so well. And I'm as happy now at 22, I'm happy now at 57 as I was in 22. So anyway, it's an honor for me to join you. And I will tell you by way of career that I have always cared about the most challenged children in every setting that I work in. So I'm not sure why I like to be told off and flipped off, but I do. I love it. There's something about that just gets my brain all lit up. So I have spent half of my career in schools, and I'm a school social worker by training, but I've also worked in treatment foster care, and I've worked in mental health as a therapist, and I've worked at the university level teaching school social work. And now I'm sort of in the sunset years of my career and chose to come back to the nonprofit world to be a director of mental health programs that do primarily in-home and wraparound services with the most challenged kids. So the kids that I love the most now, I wanted to finish my career in a nonprofit that can pivot and can make some good decisions for our community. And that nonprofit is in Madison, Wisconsin. You'll see in by way of introduction, I was also a Department of Public Instruction school mental health consultant, and it's this voice that I will use with you today. And Louise Wilson was my comrade. I mean, how lucky is that? So feeling super fortunate to be here and have traversed some very interesting, I have to thank the families and the children who have trusted me enough to share their stories, because they inform, most importantly, the work that I do. So next slide, please. So first thing I'd like to do, and if you have the inclination, you're welcome to pull up the chat so we can create some community together. I'd love to hear from you on some of the questions that I've posed, which include, what kind of supports did you receive in school? Yeah, to support your mental health and resilience. I want you to go back to when you were a child or teenager. When stressful times were in play as a child or teen, was the school part of your support system? And was there an adult at school that you can name who believed in you and that made all the difference, a teacher or a coach or whatever? So if you would just throw some ideas into chat, like yes or no, I was supported. Yep, there was a teacher that made a difference. I would love to just hear, because we're going to look at this historically a bit. And so many of us in this room were in schools maybe 20, 30, 40 years ago, some of us. And so what do you think? Why don't you weigh in here? Let me know in the chat if you received support or didn't, and what that looked like if you're willing to share. Yeah, absolutely, Sean. Extracurricular activities are part of resilience, 100%. And Dr. Namsaria, you don't remember receiving anything. And maybe wouldn't even think to turn to schools for that. Yeah, see, isn't that interesting? It didn't occur to you all to ask for some support with the stress you were going through. You might have talked to a teacher you felt close to. School was more of a focus on academic development. True. There were teachers available for you, Kia, who you could talk to about what was happening. A high school guidance counselor, Katie, that's awesome to hear. School was safe in general, Kathy, that's good to hear, maybe not a single adult. And then there were some people who accidentally went into your life, Dr. Nasaria, and kind of gave you what you needed in the moment. I'm glad to hear that. Yeah, teachers showed up. Teachers are pretty powerful protective factors. When teachers speak, the children believe them. And when teachers listen, they do feel helped by them. So teachers, I always remind people, teachers, the power of their influence. Okay, you actually benefited from a group, Allison. That's great, because there are definitely some structured services. So if we see a little bit of structured support through a guidance counselor or a support group, and a lot of kind of informal relationship building, some safety, some teachers who leaned in. And then Sean, the extracurricular stuff, I can't emphasize that enough. It's a very important part of resilience building. Whenever I'm teaching about resilience in schools, I give a special nod to coaches, to art teachers, to music teachers, to help them recognize that they have a role to play in supporting the mental health of children, for sure. Okay, so, well, Sean, we're going to take you on a journey here. You're going to learn some things about individualized supports and group supports and school mental health. That's why you invited me here. So I'm going to give that a try. Okay, thank you, Anne, for sharing. All right, so next slide. Thank you for kind of weighing in. Let's see where we've been in schools related to mental health, and let's see where we're headed, and let's do that together. So how did school mental health become a priority in Wisconsin schools? You know, so as Louise is such a wonderful example of, the student services staff in schools, which we consider counselors, nurses, psychologists, and social workers, of which I am of the social work type. We create interdisciplinary teams to meet students' academic and emotional needs. So I would say that the mental health needs of kids in schools specifically has has been held within these 4 professions. And I think counselors were first out of the gate in the early 1900s. And then the whole profession became more in ascendance, I would say, in the 50s, 60s, 70s, and continues to be an important piece of, yeah, thank you. In the 50s and 60s, Jeff is weighing in. Support from school personnel was at once more informal and personal. And now it's, yeah, for kids who are in real trouble. So the profession, those 4 disciplines have been in play for 3 or 4 decades now, and we were asked to meet as teams, interdisciplinary, to bring our skills as psychologists and social workers and all that together to look at, I would say, primarily academic needs was the focus of the onset of the profession, but that's evolved. And what I'm going to focus on more specifically is the last 10 years. Invite you into considering this for a minute. When in the last 10 years in the state of Wisconsin, there has been a deep and wide surge in a focus on school mental health and student mental health. And it's come from multiple directions. I would say most importantly, it's come from principals and teachers identifying. If you ask them, I want some professional development, what do I want to learn about? Number 1 is trauma and number 2 is mental health. What? So think about what a shift that is, right? Where our leaders and our teachers are asking us for how to support students emotionally at a time where their charge is to be in charge of reading curriculums and math curriculums and social studies and all that. But they know, and I think viscerally understand in a way that we didn't before, that children are not just lift the forehead and pour in information. That's a metaphor that's old, that doesn't stick anymore. So we know that we're integrated human beings and that our emotional well-being impacts learning. And that is in display and very much a priority in Wisconsin. And so we have had teachers and principals sign up en masse in the last 10 years to understand the impacts of trauma and mental health on children, on their learning, on their families, on their development. And it has been an exciting time for people like me who care about kids, and many of us who share this desire to see that integration of academics and emotional well-being, very intentional. At the same time, DPI came into a lark and got a bunch of money for federal funds to look at schools, to look at safety, to look at mental health, to look at culture, to look at positive climate, and to look at mental health specifically. So at about 2014 is when I jumped into that fun ride, and I was invited to be in charge of a $10 million grant called Project Aware, which was focused explicitly on school mental health. And they hired me on, and we were some of the foundation was building. We had a lot of money in our small team. Now imagine a team of maybe 15 people holding this work. It wasn't a lot of people, but we're deep into it. And I said to my boss, this is the first time I'm a social worker with money. So first off, what the heck is actually happening right now? I'm like beside myself. Secondly, I don't want to do this work without a framework. There has to be some curves on the road for understanding what school mental health actually is. So in good fashion, we scanned the resources across the nation and found a couple of good examples, which we adapted for Wisconsin. And the school mental health framework was born around 2016-17, and schools were hungry for learning it, which is pretty cool that they were sending staff in teams to learn about how to create a continuum of supports in schools that would help kids with mental health challenges and also help kids stay well as well. So that is currently being updated. So if you wanted to go peek at that, you can go ahead and look online on DPI's website, but it's under construction again, my friends tell me, which is wonderful. So we got cohorts of schools together for multi-year learning to look at issues of, particularly you're going to hear about 3 things: social emotional learning, which is our universal strategy for development on how kids learn about self-awareness and interpersonal relationships. You're going to hear about trauma-sensitive schools, which has been a big initiative in our state. I can't wait to tell you about that. And then you're going to hear about school mental health. So those 3 priorities were together, like bundled together to bring schools along in understanding a continuum of supports, which I'm going to show you in a minute. And then our superintendent, Reed Governor, Tony Evers, who happens to be like a guy I know, like I have pictures of us together, which is totally cool. And he said, I want to put mental health as a priority in our framework for education. And he did it. And he framed it as an issue of equity. That we all need, we might need an extra lift to get what we need to be at the table to learn. So to have that endorsement, think of that, funding, leadership support, schools being interested, teachers and principals signing up en masse. Can you imagine a more exciting time to hang out in the world of school mental health in the past decade? Wow, it's been an honor and very exciting. So then I want to give a nod to a new grant program that was created, and that was because there was a little ask about money and funding. So some of the funding was federal funds that came in via grants. Some of them, we started a new program, and Kathy Markland is in the room from WAFCA. She was our partner in that, along with Linda Hall. And we met and met and met. And there's another group called, you'll have to give me the most current name, Kathy, but Advancing School Mental Health Collaborative. You can help me with that later, Kathy. But basically, we were dreaming about how to get schools money to develop their own mental health projects. And we needed a nonprofit partner to do that, and we did it. So back a few years back, it was a $3 million program. Now it's a $10 million program, codified into our legislator and into funding for schools to get money, $75,000 a year, $150,000 for a 2-year cycle, to develop their own initiatives to meet their kids' needs in the world of school mental health. And so, and it's, I still shake my head when I tell this story. I'm like, oh, pinch me. So WAFCA was an important partner, and I may rely on Kathy later to be my wing person because she's so knowledgeable in this area. The other thing that's happened is there's been an increase in funding to expand the student services teams I told you about. So school nursing, school psych, school social work, and school counseling have been really underfunded, I would say. There are big ratios of kids, 1 to 400, one counselor for 400 students, one counselor for 800 students. It's not, it needs to be improved, and we're putting additional money at the state level into those 4 professions. You can see in the, oh, and Allison and Kathy are both telling us what the exact name of that group is, Coalition on Expanding School-Based Mental Health in Wisconsin. So you see there in pink, way to go. When the states and districts begin to collaborate, and there are learning and coaching collaboratives to look at what school mental health is and money, an initiative is born. So next slide, please. So this one might make you drool a little bit. Just relax. It's all good. There's a lot of words on the slide, but I'm going to take you through it just gently. I'm not going to read it to you because I trust you. But when we think about a continuum of supports, it is exactly that. It starts in the world of prevention. You know, before things get hard, what are schools doing to support kids emotionally? And you can see social emotional learning. That's like what I would call bringing teachers to the table to embed social emotional learning objectives into their curriculum, into their advisories, into different ways that we recognize that the kids are growing up with us, and that development on interpersonal skills is an important one. So that's had a lot of attention. The trauma sensitive schools, I gave you a teaser on that, and I'm going to tell you a little bit more about it because it's pretty darn exciting. There was a work group. This is how work always happens. A small and mighty group of people care about something, and then they just make stuff happen. Isn't that how this goes? And they were doing it with no money, but they realized the impact of trauma on learning. So they convened multiple stakeholders across multiple professions, right? Teachers, therapists, docs, peer support, parents, and they sat and they said, we've got to get the word out that trauma is impacting learning. And so that's how it started. The grant funding came in, we hired some consultants, we worked with the smartest people we knew, and there's now an entire online learning system to support trauma sensitive schools. What is trauma? Fight, flight, freeze, the neurobiology of trauma, moving into strategies in the classroom that can help promote and understand how trauma impacts learning. And probably most importantly is how to understand behavior through a mental health or trauma lens, because in schools, we're sort of notorious for thinking that the children are acting up willfully. I'm gonna let that sit with you for a minute. We think that they're doing stuff on purpose or that they don't care. And unfortunately, our attributions have been cookie cutter, like get with our program or there's something wrong with you. We're a conformity institution. I mean, I'm talking so bravely here in this space, so maybe keep a lid on this conversation. I don't know. But here's the deal. It's a conformity mindset, right? And so when children were outside of the box or they struggled, they were made to feel bad about themselves, or that they didn't care, or they weren't learning, or they were stupid. And oh my gosh, people have stories. So schools are either a tremendous protective factor, or honestly, we're a risk factor at times for people where there just isn't that conduit to support good learning. So what the trauma sensitive schools did was get us all to be curious about what other elements are in play in a child's life that could be impacting their learning, and including the impact of trauma specifically as not being willful behavior. So maybe the kids are doing the best they can. I'm gonna let that sit for a minute. Maybe the kids are doing the best that they can, and when given some additional support, and if there's a trauma trigger or something that happens and they freeze up in class and the hood goes up, maybe that's not I don't care, maybe there's something going on. Or maybe when they shout back at a teacher and that's a fight response, do you see how we're going to deconstruct that willfulness into something that we can get curious about and work on together, and maybe get the kids the support that they need and deserve? So that's what trauma sensitive schools is all about. And it looks at discipline. It's just incredible. If you want to check that out on DPI's website, I couldn't be prouder of the ways that schools can engage with support, with coaching in the learning. They can also do it on their own. It's been really fun to watch. And then there's mental health promotion for students and staff. And I think there was a specific question from Kia on mental health literacy. And that is happening in health classes and in other classes. Language arts teachers are choosing very interesting fiction and literature to get teenagers and other kids to reflect on differences, on stress, on emotional. So you can choose your curriculum to reflect a more mental health promotion lens. We do it in health classes, we do an advisory, we do groups for kids. And then I mentioned mental health promotion for staff. I want you to tuck that in your pocket because we're going to come back to it. Trust me. So positive teacher-student relationships, you mentioned that in the chat. That's people are recognizing the power of their influence in academics. Kia, thank you for throwing up the link there. It's there for you all now to check it out. Culturally responsive practices are for all kids. Where are we seeing culture as a protective factor, where kids feel welcome to bring their individual strengths and to the classroom? And again, deconstruct that conformity mindset. Who are you? What do you bring as your gifts? What faith do you have? What rituals do you have? How is your family different than the rest of us? So anyway, lots of good stuff. And then achievement and wellness are connected. So you see those main foundational ideas, and then there are support for some kids. So can you imagine an institution that's better equipped to do early identification for kids who might have mental health challenges, whose development is beginning to pause because of stress in their family? It's schools, for sure. So we have a tremendous opportunity to see when kids are struggling, to offer them support, to engage other systems when we need to, child welfare, mental health counseling, after school programs, our physicians, our nurses for consults, all of that. There is some screening that happens in schools as well on all kinds of levels. Some schools do intentional depression screening, anxiety screening. Some kids do suicide prevention screenings. It's not universal, just as Louise said. We don't put out a mandate that says this is how every school needs to act. Our schools are run by local school boards. And so, but we have lots of options for people to buy into what their local community needs. And then we're monitoring progress, we're working with families, we're making referrals to the community. And ultimately at that first stage, my wish and my hope is that when we're beginning to see kids off track, attendance is lagging, there's some stress, the learning is that we wrap a circle of support around that child. And just an informal support. It might be mental health services, but it could look like a whole lot of things. So for example, when I conducted attendance meetings in school, when kids were missing too much school, my first question was, who loves you? And can I bring those people in a room to support your attendance? And that might be grandma, auntie, it might be a peer, it might be anybody, but that's an example of a circle of support. Yes, Jeff, you're on to me. So Jeff says it reminds me of positive behavior interventionists and supports with PBIS. It's 100% relevant, Jeff. So I'm showing you the tiered system of what's for all kids, what's for some, and now support for a few kids. I'll keep us rolling here. So when we've really seen kids struggle, we look at a comprehensive assessment. We've got to rule out anything that might be biological, anything that might be mental health related, and we want to provide supports that actually meet needs, not this cookie cutter stuff that we get into. We want to deepen our collaboration with families and community providers. And I'm a particular fan of the wraparound approach, which uses youth and family voice and choice at the center and bringing services to where families and youth work, live, and play. And then we want to focus on emotional regulation skills for the kids who really struggle, because those are the things that get them excluded from jobs, from school, from friendships. And then we want seamless reentry and monitoring progress at that intensive level. So you can see we're moving across the continuum where the dose response increases based on need. And now we're teaching kids or schools to create those systems of support where there's actually a referral pathway. We identify a student, we identify the supports, we move along. Is it resolved? Things are better. We release those supports. We lean in more if kids need more. Next slide, please. So when is comprehensive school mental health at its best? And I would say it's when the community works in tandem to claim the child's well-being and growth as if it were their own. So it's not somebody else's children. These are our children, right? And where I really saw this happen most effectively in our state was in small rural communities. I saw such beautiful things happen in our smallest towns. Now you would think that they're under-resourced, right? There's not psychiatry, there aren't enough therapists, true, but they claimed their children like they were their babies. And everyone mattered. So sometimes in the more urban settings, we see some shifting, some turf. This is somebody else's kid. And so I'm just going to offer that up. And the more differences we have in our community in terms of how we look or how we, then we begin to otherize. We begin to separate ourselves. When communities claim that everybody has a stake in children's well-being, I'm telling you, magic can happen, even with scarce resources. The other thing that works really well is when there's seamless referrals and continuous communication with youth, family, voice, and choice at the center. I have never found the children to be the hardest part. It's the grown-ups. I'm going to be honest. It's not the kids that are hard. It's getting the grown-ups to work in concert with each other on common goals, clarity of roles, and focus on strengths, not on what's broken. That's where the magic lies, in my personal belief. And then in pink, there's integrated therapists into schools, and this is happening statewide. And this has been really accelerated in the past 10 years, is that nonprofits and other even hospital settings who have outpatient clinics are being invited to place therapists in schools. So we're taking the mental health services to the children, again, where they work, live, and play. And we're having the kids, so there's no obstacles around childcare. There's no obstacles around transportation. The kids can get their mental health supports right in the schools in a collaborative relationship between nonprofits and schools. It's been amazing to watch how much of that is happening. And that's funded primarily through Medicaid and insurance. So, the folks are billing through their clinic. And the schools are creating the space and sending the kids in the direction that need the mental health supports earlier, because why not prevent needless suffering? Why not? Why not? So the therapists tend to see the kids in the middle of the continuum, or on the high end of the continuum, I would say. And then of course, we want all of you, the physicians and school nurses, are integral to the management of the mental health needs. And then finally, a workforce development strategy to address statewide shortages, because we got them, folks. And there's a number of our state departments who are looking at this, Department of Health Services, namely, to say, you know what, we know that there are not enough therapists in our state, and that we need more psychiatrists specifically. And that's at crisis levels, frankly. So we need that as well. Next slide. So what about the pandemic? And this is where I want to see this chat light up again, if we can, because I trust you all. What do you think is happening, or what are you seeing as the primary impacts of COVID on student mental health? And what do you think might by hypothesizing, where school mental health initiatives in our communities, where they're getting launched and where they struggle? Let me hear from you on this one. What are you seeing in kids? And what do you think are the strongest factors that influence school mental health initiatives at the local level? Light up the chat for me, would you? High anxiety, 100%. Anxiety levels are up, up, up in young people. Yes, yes. Difficult transition back into the classroom. We are seeing more dysregulated behavior from the children, more acting out, more distress for sure. So much, yes, Laura, so much anxiety and depression. Kids are worried about missing school, getting behind. The peer relationships are more fraught. Suicide attempts at the middle level more than I've ever seen. I'm so sorry to hear that, Shannon. Our babies, I'm telling you, 11 to 14 years old, and we're seeing suicide attempts. Yes, anxious parents too. Our families, my goodness, what they've been through. All of you in this room, if you are at home and you're raising your children while you're doing your good healthcare skills and they're driving Matchbox cars through your hair, right, while you're on a Zoom call. We've been to that place, many of us. So that's true. Dr. Nafsaria, I think students' usual supports are all over the place. That might mean home, it might mean friends, it might mean teachers, but those patterns have been thrown way off and those supports themselves are facing stress. Well said, well said. So it's not business as usual. As a result, how ridiculous the parents are behaving. Okay, so let's look inward for a minute, and I'll get to you, Sean. There's a lot. We're languishing, folks. This is it's hard to stay in this pandemic. Like we had some initial kind of, adrenaline going to get this going, but it's 20 months later. So parents are struggling 100%. The children are struggling 100%. And when I think about school mental health initiatives, the thing that was the hardest, teacher fatigue, principal fatigue. So I could give them like boatloads of money. Like here's $300,000 for you to use in my grant. And they wanted to do their best, but they got tired. It was when you're so exhausted, can you learn a new evidence-based practice and apply it? Let's be clear, right? So all of us are tired, right? And our ability to learn and grow and even to frame student behavior through a mental health or a trauma lens is hard. It's hard to do that. So let's have lots of compassion for each other in that regard. So parents, teachers, kids, we're kind of all in this together. Sean mentions more screen dependence in and out of classroom settings, more socially withdrawn schools, students, and they're isolated. Yeah, so lots of kids were already in their bedrooms before the pandemic, measuring the size of their butts to the girl next door, or pursing their lips and comparing their bodies, and cyberbullying, and the guys were on screens and gaming with weapons in their hands and all that. So that has been in play for a long time. It is accelerated in the pandemic. And the thing about that is there's no serve and return, folks. So we come alive when we put ourselves into the world and people give us something back. Eye contact, a smile, right? Screens don't talk back. They don't smile at you. They don't rub your arm. They don't warm their eyes up. They don't laugh at your jokes. It's a problem, right? And so depression, anxiety is going up, and I'm not blaming the screen, but I'm blaming a lifestyle of a lack of serve and return. When stressed out third grade teachers turn to their 8-year-olds and go, what? What do you need? We're missing each other. Do you see? So I also think social emotional health is sometimes taking a backseat to perceived, oh my God, the kids are all behind. Yeah, fair enough. There's a lot of urgency around academics, but I will say the marriage is pretty good between well-being and academics these days. And there's a lot of focus like on community building and relationship building to start to spark the learning. So school report cards look immediately as academic outcomes. That's true. What does get measured does grow. I think those are all good points that you're making about the initiative in general. What else? Did I miss anything else? Okay, this is such a good conversation, and I knew you guys were up for it, because there would be so much rich wisdom in this room. Kia offers, my daughter was told she shouldn't register for certain classes because she did virtual school last year instead of in person. She's now a junior. Yeah, so the academic pathways are a little twisty right now. The mental health supports are what we're seeing. So now I'm a nonprofit director. If I'll just put that hat on for a minute. And the explosion of requests for mental health services is wild, like nothing I've ever quite seen before. So there is lots and lots of needs that people kind of kept a lid on. And we're doing mental health services, both via telehealth, and now we're doing some back in offices and in homes with masks and ventilation and all that. But I think the mental health supports are here to stay. I mean, I think it's going to take us a while to write this course, which is why a workforce strategy is important. We simply need more professionals available to support people through what we've been through, along with informal supports, your partners, your friends, your cousins, your everybody. We're going to need each other moving forward. So I think we've covered a lot of ground here. I took you through, I don't know if your hair is blowing, but it probably should be. You know, I took you through a continuum of supports and had you reflect on your own lives and then thought just a tiny bit about how this pandemic is influencing things. And what I'd love to leave you with, because I want to get you right to the panel on time, because we got lots more to learn together today. If you could, I've asked Kia to read a quote for us to just kind of close this experience and let it land. Sort of, we've appealed to your head today, to your intellect, and I'm going to ask you to let this one land in your heart. So Kia, if you go to the next slide and read that quote, I'm going to stick around. So if you have additional questions for me or whatever, continue to put those in the chat. I'll respond. But until then, just relax for a minute and let this land, because we know why we got in this field, right, folks? Because we deeply care about people. So Kia, if you would.
Okay, thank you so much. From Bianca Sparacino. The kindest people are not born that way, they are made. They are the souls that have experienced much at the hands of life. They are the ones who have dug themselves out of the dark, who have fought to turn every loss into a lesson. The kindest people do not just exist. They choose to soften where circumstance has tried to harden them. They choose to believe in goodness because they have seen firsthand why compassion is so necessary. They have seen firsthand why tenderness is so important in this world.
Okay, like I'm trying to keep a lid on it. That stuff always makes me emotional. So next slide, please. So I'm thanking you with deep gratitude for your time and attention today. And my invitation is, may the collaboration for and with Wisconsin kids continue. My email is there if you liked what you heard today or you want to hear more. I'm not in school mental health specifically, but I consider myself part of any community who cares about kids. My email is there. I want to hand this back to Kia and to Dr. Nasaria to keep your program moving, but I wonder if you have any reflections or anything you want to offer, and I'll stick around for some questions in chat as well. Thank you.
Monica, thank you so much. That was a wonderful presentation and so clearly heartfelt, and I think really helps us keep our eyes on the priorities as we try to figure out how to make this all work. It was really lovely. Thank you. We do have some time for questions. If folks, again, as before, please either in the chat or raise your hand if you'd like to unmute, and feel free to ask whatever questions may be on your mind or thoughts or comments you have. We'll give people a moment, the inevitable need to pause for Zoom if they're typing. And I'll just say one brief thing here is that, your opening question about what we ourselves remembered in terms of support, I think also highlights how much the role of schools has changed, their perception and their own perception of what they could or should provide, which are not necessarily the same thing. Laura Hauser asked the question, are there other roadblocks we haven't discussed besides money, time, burnout, and so on?
Well, Laura, you were listening, my friend. If I had to identify the things that are getting in the way, we're a very time compressed profession. Can you all relate to that? 100% you can. And then I do worry about fatigue, and I want to support people to a place of compassion, resilience. That's a whole nother topic I could talk to you about, but we're investing in the adults in various systems, the youth serving systems, to be able to convene in groups to talk about this impact of the work and how to recharge, how to stay compassionate, how to stay centered. So there are some strategies for the adults to get support as professionals in debrief and sort of talking about your work together. So, but I think those are the main, because I'm not a big believer in mandates, so some people might say, well, is it local control that all schools, because I'll tell you how schools handle mental health is different based on your zip code. So every school district is different. And there's part of me that would love to put a magic wand on that. But I also think local communities know their children the best, and they know where their strengths and talents are. So I kind of hate to take that out of their hands and make mandates. I would rather motivate local communities to find answers. So that's my preference. So Sean, hey, thank you. Yeah, well, thank you.
And Monica, I'll just throw in one other observation on a roadblock, which is that I think there's many reasons that it's great that there's so much attention being focused on all these questions, but I think there also can be oh, wait a minute, we've been working on this for 10 years, 20 years, whatever, and now some other group comes in and it's like, wait, you think you're going to solve this for us now? Like, and make all the mistakes we already made. Come on. So I think it brings a lot to about thinking also about coming in with humility to the work and really helping forge partnerships and not being viewed as kind of walking in saying, well, now I'm here to help you all. Like, gee, what's going on?
100%, yes.
Dr.
To be
Lamont
respectful of efforts before us. And I see the question from Jeff about, is PBIS, which is the positive behavior intervention support, still relevant? Yes. So it's still used in schools, and it provides great structure on knowing what all kids need, what some kids need, and what the most intensive supports are. So that is still relevant. What else do you see in Dr. Lafsario I can respond to?
I was pointing out that one, John Ashley, who will be one of our upcoming panelists, talks about local control not being perfect, but the alternative is more concerning. And I think we will dig into that a little bit on the panel. And then Ann Bierman has a great question there.
Okay. Oh, yeah. Yes. Is there any data on schools with mental health supports in schools versus those? Yes. Okay. So wow. So that's a big question. And there's so many ways to answer that. I would say in our larger urban communities, this question is being tackled very explicitly. So in Milwaukee Public Schools and Madison Public Schools, you think of the big schools, Racine, Green Bay, sort of across our state. There is a trend toward dismantling police officers in schools and calling police to shift the funds more towards counselors, social workers, and psychs. And that's like in process as we speak. So there is some direction in that area, which I feel sort of hopeful about. Is there data on schools with mental health supports in schools versus don't, and how they use the police? I don't know that. So I can't answer that directly, but I would say it just depends so much on, it's from community to community. So some police officer relationships with schools are actually pretty positive, and they'll come in curious and they'll work with people and we get work done. And in others, the control and compliance response is problematic. The other thing is for kids who are in acute distress, the ED process, like the emergency detention process, actually includes the police sometimes. So sometimes we have to call the police to initiate a hospitalization. So we have to stay at the table with our police partners to figure out how to do this well. And I think we're getting out of a co-location model and into more of a community collaborative model. That's what it seems like. But I love your question. So here's another one from Kia. Let me see if I can read that through. And Kathy M's on there. Let's see.
The question, in case people aren't able to see the chat, is regarding how are we measuring or determining which monies and investments are working and working well in schools, basically talking about quality and how do we know that what we're doing is effective.
Yeah, good question. And Kathy, if you want to weigh in at any point, you're my wing woman. So I can shut my pie hole and let you have some space here if you want. What I will say is, I mentioned to you that the schools are having learning collaboratives where 30 or 40 districts are getting together to look at best practices. DPI has been doing an amazing job as a state department in codifying some of those and giving them back to our field. We are doing some data collection on some best practices as well. So I'm hopeful in that area as well, that we'll continue to make progress on data collection and sort of what's working and what's not. But I would say it's in its toddlerhood phases. Like it's maybe not a baby anymore, but it ain't running yet. So Kathy, do you want to say anything by way of summary? I'd love to hear from you in this space.
Yeah, thank you for that opportunity, Monica, to jump in and for the question, which is just an excellent question about where we are at with our ability to sort of track out what is happening in that school mental health space. I will tell you that part of the piece that we really are tackling in this moment, and just had a meeting about recently with our partners at the Office of School Mental Health. The Office of Children's Mental Health, as well as the WISH Center, which is a really key partner through our CISAs that is really doing a lot of the lifting the load in helping our schools with their implementation components around some of these universal pieces and our curricula. That we just want to get a handle on which schools are where we even have a mapped out point map of where school mental health is happening, and using that terminology broadly, thinking about all three tiers that Monica talked about. And so it is a real growth space for us to get to anything around tracking of outcomes and effectiveness. Certainly that is something that is a goal for all of us, is to be able to say we've made these investments. We particularly want to be able to show, obviously, with the additional state investments, that this is money well spent, right? These are dollars that are making a difference. But Monica's 100% right. So much of how this manifests in each individual district, and in fact in individual schools, is so varied that it's a difficult piece to wrap our arms around. I agree. I feel positive that we are progressing in a direction that we are beyond that infant stage and into that toddler space. So that's a well way to represent where we are, Monica. But it is something that we are certainly looking at. We look at our collaborators both at DPI, with our provider community, with our state partners, in trying to continue to narrow that and have a better handle on how this is developing and growing across the state.
Well, I appreciate the developmental metaphor applied to the description there, and thank you for your extremely thoughtful response there to give us all an idea of how to think about that. And I'll just call it that Allison has put some great information also in the chat there about school resource officers. Monica, thank you again. Appreciate the library for giving you the space to be able to join us from. And please stay as long as you wish, but we also are completely understand if you want to get back to your much deserved time off. So we are now going into the last of our presentations before our brief wrap up at the end. And this is not actually a presentation, but a panel discussion. We wanted to bring in other perspectives to think about all these things around schools and health and well-being of children and all. So we brought together John Ashley, Teresa Duchateau, and Jeff Lamont, who you heard from earlier. You did meet Jeff, but I will invite Teresa and John to give a brief introduction of where they sit in the world and their perspective, and then I'll be moderating this discussion as we move forth with some prepared questions and then some opportunity for questions from the audience as well. So Teresa, do you want to start, please?
Sure, great, thank you. And thank you for inviting me to be part of this panel. As you mentioned, my name is Teresa Duchateau. I am a nurse, and for the past 20 years or so have worked in the area of school health. At one point when Aurora had a school-based health program, I was a nurse practitioner in some schools in Milwaukee and partnering with Milwaukee Public Schools as a pediatric nurse practitioner, and then got into positions of leadership within that program and was the director of school-based health along with the pediatric visiting nurses program. And then the decision was made to end the school-based health program, and that was really my love and passion. And so I chose to leave the organization at that time. But subsequently, I was given the opportunity to work on a 5-year project with the Healthier Wisconsin Partnership Program, and worked on the WISHES project, Wisconsin Improving School Health Services. And we had the opportunity to work with public schools across the state. We did a statewide assessment of school health services, worked really closely with Dr. Lamont, and based on that assessment, developed resources and tools to give back to school districts to use to improve their health services. And I'm really proud to say that one of our focuses during that project was to create sustainable resources. And so everything we created still exists years later. And I think one of the most popular resources that we created was the school nursing procedure website, where we partnered with nurse practitioners and specialty nurses to craft step-by-step instructions on how certain procedures should be done in schools. Because as you've learned over the course of today, most of the times it's not a nurse that's doing those procedures. I have also taught in the College of Nursing at UWM, focusing on population health. And now I am a co-partner in my consulting company, School Health Associates. And my partner is Betty Carr, who was the previous state school nurse consultant with DPI. So great to be here today.
Great, thank you. John.
Good morning, everybody. My name is John Ashley, and I appreciate the opportunity. I have to say there's been a lot of passion. I wasn't able to participate in the entire session, but boy, it's hard to follow Monica. That's what you call enthusiasm and commitment. And thank you for just allowing me to bask in her knowledge and her support of our kids. And I do want to just acknowledge the great work of all of the participants on behalf of our students and families. As the executive director of the Wisconsin Association of School Boards, I represent 421 public school districts. So from the largest district to the smallest districts. And I know Monica made it an aside about local control, and we could spend hours on that, Monica, but at the end of the day, this is a local control state. And I think it's important for us to understand that if we care about making a difference, if we're reaching out to our communities, a one-size-fits-all approach on the issues that we're talking about today is not going to work. Politically, it's not going to work. And also, we live in a very divided society. It shouldn't be a surprise to anyone that we've had very disruptive school board meetings this last year over the issue of masks. I don't want to go into all the specifics, but it's been horrifying. And I've put out a civility statement on behalf of school board members, and this is a public forum. I want to be very clear. School boards want to hear from their parents. They want to hear from their communities. We understand that the public may not agree with the decisions that a board might make, but that doesn't mean that the public should be threatening school board members, chalking their homes, threatening their families, following them home. We've really crossed a line, I think, in terms of our civil discourse around these important issues. And so when we talk about masks and the safety of our kids, and I know there are people that would say, well, we should just make one decision on that. And the fact of the matter, that probably would have been easier, but that's not the reality that we have. So we have also seen that across the state, different county health departments took different approaches, which only complicated the decision-making process of some of our school districts. But that aside, I think that what my message to the group is, the work that you're doing is so incredibly important. We can't be intimidated. We have to put the needs of our kids first. And when we talk about funding, it's not enough. And we have to be bold enough to say, do you not want to invest in something that is going to give you the highest return on that investment? And that is our kids. And we need to be more public about that ask. We shouldn't be embarrassed about saying it takes resources to do this work. And for people that feel like, well, we don't want to raise taxes, we don't want to, folks, we're sitting on a multi-billion-dollar budget surplus, multi-billion. If there was ever a time for us to advocate for investment in our children and in their mental health, now's the time.
Thank you, John. I'm reminded of the apocryphal line, right? You know, I'll paraphrase it here in this context that, you know, when was the best time to build strong collaboration between schools and you know, the medical world around, you know, student health and well-being? Probably 20 years ago. Okay, what's the second best time? Today. You know, and so here we are. Let's get this done. And then again, Dr. Lamont, thank you for joining us again on this panel.
My concern with local control is that it reflects local sentiment, and local sentiment very often does not have much sympathy for the most fragile and the most vulnerable. Funds are diverted to put in new lights at the football stadium. Those same funds don't find their way to improving mental health programs, to strengthening nursing services. I can tell you that at least in central Wisconsin, school districts are not inclined to hear or follow basic tenets about public health. Public health measures, good public health measures, are simple in concept, easy to implement, safe for everyone involved, inexpensive compared to the consequences of not doing it, and they are effective if everybody does it. Otherwise, it's like having 10 holes in the bottom of your boat and you fill 5 of them and wonder why the boat sinks. You know, it would be like Aaron Rodgers calling a pass play. 3 guys on the O-line decide they don't want to run it, so they just don't run their assignments. Is anyone surprised if the play doesn't work? And what do you think, what do you call those people who don't support? You know, what we've done with local control, as I said in my talk, school boards have enormous and terrible power given their control over health decisions with no health education or background or training or experience. And I can just tell you, they are not reaching out to clinics or physicians or nurses to say, help us with this. What's the best way to keep people safe? So I appreciate there are advantages to local control, but I appreciate that there are really hobbling limitations as well.
So aside from the fact that your football metaphor is completely lost on me, Jeff, since I have no clue what you're talking about with that, I want to say, though, that given that we are in a local control model, where are the opportunities for us to actually take advantage of that? And I'd just like to have each of us think, are there places where we can say, this is an opportunity for us to be able to promote student health and well-being in whatever context that might be? John, I don't know if you want to start with that, and then we'll go through.
Sure, I really appreciate Dr. Lamont's comments. I think from my perspective, it's a little bit more complicated because we have we have medical professionals who are reluctant to make the call that I think Dr. Lamont is wanting them to make, because we have districts where our districts don't fit neatly into the counties. And so you may have a district where part of your students are in one county and another building in a different county, and you will be getting two different medical directives because the two county medical departments have a different opinion about masking or quarantining. So even if a district wanted to rely on the medical professional, there's a lack of consensus within that community. And what we're also seeing in the medical community, and I'm not trying to dump on the medical community, but we do see that there are a number of medical professionals who have chosen to resist any kind of mandate on vaccination. And that's their choice. I mean, I'm not here to judge, but I do think that for school boards, it's not surprising that they're in this situation because, as you point out, Dr. Lamont, they're not medical experts. But when you have a lack of a consensus at the statewide level by health departments, it shouldn't be a surprise to anyone that some boards are going to be influenced, and this is not a defense, but influenced by the loudest voices in their particular communities. And I think we would be disingenuous not to acknowledge that there are parts of the state in which decisions are being made based on economic discussions and on the impact of businesses rather than on the health of our students.
I would agree. When I have spoken at a school board meeting, I've pointed out that organized medicine is unanimous and united in supporting common sense public health measures, whether it's a government agency such as the CDC, a national or state organization such as the AMA or the Wisconsin Medical Society, a nationwide professional organization, specialty organizations such as the American Academy of Pediatrics, American Academy of Family Physicians, or large clinics such as the UW or Marshfield Clinic. Yeah, there are the dissenting voices, but they need to be, and they haven't been, they need to be recognized as outliers and dissenters, not the voice of the vast majority of healthcare providers who are trying to keep from having to care for people with COVID. You say, why would you not listen to people who are saying this is what needs to be done to prevent? The paradox of prevention, of course, is that the more effective it is, the less evidence it leaves that it was necessary.
Teresa, what do you
And,
think about opportunities that within a local control model, are there places where we can actually move forward? Because I think it's clear how much of a quagmire there is.
Yeah. Well, I think that one of the things that COVID has done has created partnerships and channels of communication amongst individuals and groups that weren't necessarily as strong pre-COVID. So for example, I would say that many school nurses didn't perceive themselves as a public health professional prior to COVID. But when COVID struck, there was this direct linkage to public health departments in almost every school district. When we were in the height of trying to figure out what should the school do to respond to COVID, school nurses and superintendents and principals were having weekly meetings with their public health departments. They are on a first name basis now with their public health officers. And I think that that's an opportunity that we should continue to look at. How do we strengthen and how do we find more opportunities to continue that collaboration? Because although COVID is going to hopefully soon dissipate, we're going to have other challenges in the future. And I think that, I had the opportunity to speak with the folks from the Wisconsin Association of Local Health Departments and Boards, and they were looking for opportunities to continue that collaboration with school districts because they feel this is an opportunity as well. So I think that's one way to continue to collaborate. I think there's also, when Louise was speaking before, she was saying when we talk about school nurses, we really shouldn't talk about them in kind of the same sentence as COVID, because they went from being heroes last year to being the villain this year. And although I think that that's true, I do think that COVID has increased the awareness amongst many more people about health and the impact of health on school and educational outcomes and mental health. And so I think that we would be remiss if we don't try to shine a spotlight and continue to find opportunities to strengthen school health in the school. I completely agree with John. I think we need to have strong voices about increasing school funding. I also think that there were physicians within communities that stepped up and started speaking. So maybe they had children in that school district. Maybe they decided to join the school board. So I think that those individuals should also continue to forge a relationship with their school districts, get to know their school nurse, even if they're not going to be the medical advisor. Having that support, having that person, many times school nurses do present at their school board meetings. And so having a healthcare provider there that can validate what the nurse is saying is the truth. That's also, I think, really helpful because nurses are so isolated. And so I think those are some opportunities that I see we can continue to focus on and not lose sight of.
What I'm hearing from you is really highlighting the importance of pre-crisis trust building, right?
Absolutely.
That let's face it, right? Like a lot of times the interaction between health and medical professionals in a meaningful way or a substantial way was, oh my goodness, we have a pandemic on our hands. Hi, we're meeting for the first time, and I'm being so generalizing here, right? Because there's so many examples all over the state where that wasn't the case. But if you don't have that foundation of trust and communication on small things or less high stake things or less in the public view, it makes it harder to hold those connections later on. So I think there's so much that one could do when thinking about schools and health and well-being. And there are things that I think we know are very much in the scope of what we might do, right? Thinking about things that affect children, during their school day and so on. And then there are things that are probably wildly out of scope. I don't think we're going to start doing open heart surgery at schools anytime soon. Where is the line on that? Because I think sometimes schools can feel like, we've started to become all things to all people. Where do we draw that line? Do we have thoughts about what is or isn't appropriate for schools to be involved with around students' health and well-being? Dr. Lamont, let me start with you on that.
I think that pretty much is the will of the community, to look at what would constitute barriers to delivery of healthcare in schools. A lot of it comes down to non-medical things like how do you bill for services and how do you secure the privacy of the medical record. In areas where school-based health systems are robust, you often find that there's only one major insurer, for example, where there's no question about how the billing is done. There's no question about the consistency of the where the medical record goes and who has access. Everyone sees the advantages of being able to deliver care in schools. The devil often is in the details. Employers would make out because they'd have a more stable workforce because mom or dad doesn't have to leave work to see a sick child. The sick child is seen more expeditiously. And if he has to go home, it's not just school policy that's dictating it. It's the fact that the doctor or the nurse practitioner saw the child and said, Tommy needs to go home. Mom or dad make out because they can stay more focused. They know the child's being taken care of. They're not missing time from work. So everybody on one level would make out with a robust school health and medical care delivery system. But as I say, it's the administrative issues that very often get in the way.
John, what are your thoughts on where's that line where things are in or out of scope for these sorts of conversations?
I think it's an excellent question. I agree with Dr. Lamont. I think that the collaborations that we're seeing between healthcare providers in our school districts has been enriched in the last couple of years as a way of maintaining staff. As Dr. Lamont has pointed out, if you're a staff person and you're able to get some health care provided right in your district, that's a good thing. And certainly for our students, it's a good thing. The other side of it, and I always end up on the political discussion here, but there is a perception in the public in general that schools have expanded their portfolio too much. That back in the day, it was up to the parents to take care of these things. Now you're talking about maybe having dental service provided. You're talking about having physicians able to give physicals. And so there's a group of the public, tax-paying citizens who are fundamentally uncomfortable with this expansion of what it is that schools represent. You can contrast that with the development of community schools, where we're saying that our schools are the hub of our communities, especially in some of the rural parts of the state. And so the more that school is able to provide, whether it's mental health or healthcare, that's a plus for that district. But I think we would be naive to just assume that the general public is comfortable with the idea that we're saying, and I believe this in my bones, that we need to be there for our kids. That may be the only place that they can access some of these services, but there's a countervailing voice, and a strong one. And I can say publicly in our legislature that you have expanded beyond what it is that schools need to be about. And so I think those of us on this call need to be realistic about acknowledging that there's value, but also understanding that there is a group that does not agree with that perspective about bringing together resources under the umbrella of a community school or a school district.
John, I think there's something you said, though, that I want to highlight, which I think was an interesting element of framing, which was you can talk about this as what is the correct role for a school to play, and how expansive should that be? Or we could talk about children and say, what is it that the child's needs are, right? And kind of bring that focus back to the child's needs rather than about the identity of schools there. And I think that's an interesting way to frame the conversation. Teresa, what are your thoughts on this?
Yeah, kind of a follow-up to that is John was speaking. I think, we have in the healthcare fields come to understand what it is that impacts a child and a child's health. I mean, the topic of social determinants of health and what makes someone successful as an adult and how important education is, and understanding the barriers that prevent a child from having their fullest potential for educational outcome. And so I agree that if we frame it around the child and what we know about child development and educational attainment, I think we can make the point a little bit more about why providing healthcare in schools, dental, mental, all of those types of supports are so necessary if we really want to see children flourish into productive adults. But I think also along those lines, this idea of local control and when we talk about what's in scope and what's out of scope, I think it's important that we bring it down to the local level. I think there is evidence to support that there should be certain things in all schools, but to be able to then create that as an action in school districts, we have to understand what is it that the district and the community feels are needed in their schools and use that as a starting point to then bring them up to par with what's an expectation. I would love to see that every school district has a full-time nurse, regardless of the amount of students in that district. I think one of the things that I heard in today's conversations were just how many opportunities we're missing because of the lack of resources. If we had a nurse in every school district, I mean, the National Association of School Nursing recommends a nurse in every building. We've got over 100 districts that don't have a nurse, so we're not going to get to a place of having a nurse in every district. But if we could have folks in communities say, can we just have a nurse in our district? What could we accomplish? And how many of those collaborations with mental health providers and the social worker and the counselor in that school, how could we then create that circle of support around a student, having that fully functional team that are all working collaboratively together? So I think it's really kind of getting back to what is it that the community feels is needed? How do we start to implement that? And then how do we build off of that so that we can start to bring in some evidence-based services?
Thank you. So thinking about, all the different facets of this conversation, who's not in this conversation that really needs to be? And what are the best ways to engage them? Again, trying to go for a goal of more light than heat, in all those ways. John, let me start with you on this one.
Thanks, Dipesh. I think who's not here is our political representatives, because we need a sustainable funding approach to doing this. I think that those of us in school and nonprofits, we're willing to give our blood and tears for this. But the fact of the matter is it's an investment for the state. And so I feel like we can't ignore the political ramifications and in engaging with those that actually control the purse strings. And the other part for me is more involvement of our institutions of higher ed, because we have a staffing issue. And we need to look at what are the impediments to getting more nurses? What are the impediments to increasing the number of counselors that are being graduated? And we have to look at the model that we've been using, because it's not delivering for us. So for me, those would be two additions that I think would help in our cause.
Great, thank you. Jeff.
I'd like to see more involvement of groups like the Wisconsin Manufacturers and Commerce, local chambers of commerce, because they are the economic engines of their communities. And, we've seen employers that have established on-site clinics for their employees in an effort to bring healthcare closer to their employees. Having them at the table, helping them understand what they have to gain by supporting better healthcare for children. Again, the watchword for pediatrics is prevention, and you go and try to get entities in the community to appreciate what comprehensive programs of prevention for children would mean for the health of and the future of the community, and then to say, well, where would be the best place to deliver such care? And the fact is, it could be most efficiently delivered to the greatest number of children if it was done in the school setting.
Thank you. Teresa, who are we missing?
Well, I think back to my earlier point, public health. We should definitely have them at the table. I think they bring a different perspective back to Dr. Lamont's of prevention and where's the best place to implement that. And I also think parents, I mean, many of us are, I'm a parent, I have school-age children, but I think of them and schools with two different hats, you know, my nursing, my school nursing hat, but then also my parent hat. And so bringing folks in that are parents and that perspective, I think is really important.
Glad you said parents. That was the one going through my head. And we need to remember that parents are a subset of the public, right? And sometimes when there can be public dynamics about how we shouldn't be providing X or Y, then having people raise their hand and say, well, excuse me, hang on, my child needs X or already receives Y, and I'd like to keep that. And it does make a difference. It humanizes, right, it from this abstract principle to something that's making a difference to your neighbor or your friend or your coworker or things like that. So I'm going to ask one more question, and then we'll turn to questions from the audience, which I know there's already a couple coming in, but this is, well, hopefully it's a brief one, but if there was one practical objective that you would like to work on starting tomorrow that you said, you know, I think we could get this done and there would be, you know, good positive outcome from this, what would you choose? John? What would you go with?
I apologize to Fish. I just put something in the chat, so I wasn't listening.
I was just asking about what if there's one thing you'd like to start tomorrow, like that you would like to work on starting tomorrow that you think would have good bang for the buck, so to speak, for the investment of time. What would that thing be? What would be on your wish list of the single thing that we could move forward on?
I think the thing that I would tell our school districts and by extension all of you is that in order for this to really continue, because if we lose the present practitioners and the people that are passionate as they age out or retire, I want districts to put into policy their emphasis on their students' mental health needs. That has to be in policy so that once the board shifts or you get a new superintendent or all of the teachers have changed, you still have in policy so the public can come in and say, what is this district about? What are they committed to? Oh, let me take a look at the policy. Oh, they're saying they're interested in making sure students have good mental health and well-being. And so I would just say that's something we could do immediately. And that is to go from talking about this issue to embedding it in the policies of our districts.
Great. Jeff, what would your thing to start working on tomorrow be if you had resources and time?
Oh, I would like to see, well, I agree with strengthening mental health. I would like to see the role of the school nurse, the school district nurse and health systems made more prominent to the public. I think the public needs to better understand the scope of what it expects through law or otherwise school districts to provide in the way of health care. I would like to see a strengthening of relationships with public health. And I would like to see obvious public strengthening of relationships between school nurses and the clinical entities that serve a community, since they're the ones from whom so much specialty medical care emanates. You want to see that the bridging is obvious, that there is a clear continuum of care, and that the children are well looked after.
Thank you. Teresa.
Well, I would echo what John and Jeff said. I think embedding some of this into policy is really important. Heightening the role of the school nurse, can't emphasize that enough. I think one of the things that was said, I think Louise brought it up, or Dr. Lamont, I think, the laws in our state that govern what schools need to do related to health are called emergency nursing services. And we all know from this conversation today, it's so much more than emergency, but it's also really telling that that's how we frame it in our state, that, we're only going to focus on the emergency aspect of what children need in schools. And so I would also say the collaboration and continued partnership between public health and school. I think just having those resources just helps to support the school nurse because they are so isolated. And one thing that I would throw out, this is a conversation about the collaboration between primary care and schools. Something I've dreamt about for years is how do we embed more transition planning into public schools? We have these children every day, and there are so many of them that have chronic illnesses that will not go away when they become an adult. And if the purpose of school is to prepare students to be active in their community, and giving them that opportunity to learn how to manage their health and to manage their chronic condition. But we need full-time nurses to be able to be that person in the school that helps to create that curriculum to support those students so that they then can manage their chronic health conditions. So they're not misusing healthcare and increasing. So there's just so much that we could do. So those were some of the things that I dream about that we could do in public schools.
Thank you. I appreciate that forward-looking thoughts from all of you. I'd like to open this up now to questions from our audience. I see in the chat, Sean, you asked something that's in a couple of parts here. I wonder if you might just want to unmute and kind of and ask your question that way.
Yeah, thank you all for sharing. And John, you have sort of brought this up, and and Teresa, of course, you too, in terms of embedding into policy school health work. And I'm kind of wondering if you know of success stories or examples around school district wellness policies in particular. Again, thinking about, okay, given the reality of local control, what levers do we have available? And one that I'm familiar with and I'm looking into more here in Madison, and in MMSD in particular this year, as their school district wellness policy is up for renewal, is how we can use the binding parts of that policy to maybe try to create accountability and ultimately budget commitments if we're dreaming big within that policy, rather than it necessarily just being sort of value statements around every student will have the opportunity to have access to outdoor learning, things like that. Like that's sort of what the policy reads now. And then the other parts are sort of in this procedure section which is non-binding, but that's sort of getting into the details. I'm just sort of wondering, best practices in Wisconsin or otherwise around those required school district wellness policies that have to be approved every 3 years per the USDA school lunch participation.
Yeah, that's a good question. I think that the answer is that there are some good districts, and I'll just through not in any order, but certainly Sun Prairie and Middleton, Cross Plains, Howard, Suamico. We have a number of districts that have, I think, very good policies regarding student health and wellness. You did mention about specific dollar amounts and and moving from a more general description. That's really not the purpose of the policy. You actually could do more harm, because if you put in a certain amount and through some fluke there was available more money than what your policy allowed for, you'd be leaving money on the table. So there's a level of trust, and I understand that the public would like to have those dollars in there because then they can sort of hold the district accountable. But the purpose of the policy is to say, this is what we want, and then it gives them that flexibility to figure out how to get there. And so you want to include your staff and those parents and those students. And you can't do that in a policy. What you want the policy to do is to say, this is our aspiration. And then you have a process to make sure that you're hearing from the people that are affected. And I just want to say loudly, let's listen to students. That's our product. And it amazes me a lot of times when I talk to school board members, how have you heard from your school board? I mean, your students, and what they'll say is, oh, well, we heard from the athletes, or we heard from the valedictorians, we heard from, our honor students. And I'm like, no, what about the students falling through the crack? Those are the ones that maybe have some insight. And I do think it's an opportunity that we sometimes lose, which is not to listen to what our students have to say. I hope that answered your question, Sean.
And I think it was a great question, because it is asking fundamentally, like, where are the levers that we could pull here that already exist? So great. Dr. Behrman asks about health, if it would be great if health courses were mandated by the state in all schools that focus on taking charge of your health, about medication, nutrition, fitness, reproductive health, and so forth. I think it's fundamentally a question about, what's, how much do we or don't we do around health literacy. And again, this is of course different in different places based on what various schools and school boards are wanting to implement within districts in different places. I don't know if anyone has comments or experience with that.
I'm sure it's not going to come as a surprise that mandating it without funding is not something that I think is helpful to our districts. I also think we have to trust our teachers. And there is this perception out there that somehow our teachers, I mean, they've been doing this for a long time. And I'm not sure they need to be mandated to do certain things. I understand there's an accountability piece of it, but also embedded in it is sort of a distrust of our folks teaching our kids, that they aren't putting our kids first. That just hasn't been my experience, because you don't go into teaching for the salary, I can tell you. So I do feel that there's some good to be had about talking about what is good curriculum for districts, but I'd stop short of saying you must do A, B, and C, because a certain district may approach it, have it embedded in different courses and do it in a different way. So I guess I'm back to local control.
Speaking solely for on the medical side of things, we have the same conversation all the time about legislative mandates that you must do this or say this and so on. There's certainly multiple sides to that coin. Know if Jeff or Teresa had any other comments on that.
Well, I have sat on the last 2 or 3 human growth and development curriculum committees in one school district. And, that's another example of the loudest voice. You know what is right, you know what is medically and scientifically accurate, and you know what some very loud voices in the community don't want taught. And so the question then becomes, who's right? How do you decide to proceed? And why should students in one district learn about something that is medically and scientifically accurate, and those in another district get a very diluted or no version at all, solely on the basis of administration, which again is largely medically naive.
I'm reminded of, gosh, I think it was a little over 10 years ago, there was a bill passed in the legislature, the Healthy Youth Act, which did place some requirements on schools that chose to teach growth and development curricula. And fortunately, it was repealed in the following year, I think, so it didn't have a whole lot of time. But it really, the debate and the legislative actions did bring to bear a lot of these questions, right, about what is the role of schools, what is the role of what we think about information and all. It was thinking about it now, it was an interesting foreshadowing, I think, of a lot of conversations we've had around the pandemic as well, around thinking about health literacy and how we interpret what is out there. Other questions from anyone before we move to our wrap up? There's a lot of wonderful comments also in the chat that if anyone is not speaking, great back and forth there as well.
I have a question for John. If there were a way for our chapter to improve communications or really start communications with your organization, because I think one of our delights today is that we've never taken the opportunity to invite you into this conversation or into one of our meetings or discussions before. And I think it's just, we just take the opportunity seriously and like I said, with great delight to try to mine the opportunity. What would you see as something productive for your members, or something that would be helpful for your members coming from pediatricians in the state?
Well, thank you, Kia. And you and I have worked on a lot of projects as well as with Depeche. So I really appreciate the opportunity to join this group. I think that just getting the message out, writing an article maybe for our school news. We have a conference. Hopefully we'll be able to be in person with COVID, but maybe a presentation. What would be most important, though, would be for it to be at a regional level. So, for example, if you're up in the Fox Valley, if your chapter or there's a school district that's in, that you're working with, that story is going to resonate more than if the school boards association says you should do this or you should be aware of that. I think we just need to acknowledge that we live in a very divided state. We're not unique, but one of the things is it's very partisan in our state. So any message is going to be seen through a political lens, even if you don't want it to be. You want to talk about masks? Well, I can't break it apart from people that tell me you're trampling on my rights. You're trampling on my rights as a parent. I mean, that's not science. But if that is a deeply felt opinion, we have to accept that. There's no way, you don't get to change somebody's worldview. And so I think that's the challenge. And so I think going forward, I would be happy to work with you, Kia, to figure out how can we craft it at a more local and regional level, because frankly, people up in Ashland are going to say, well, if that's good for Green Bay, it can't be good for us. I mean, that's part of the dilemma. I think Dr. Lamont put his finger on it, is that's what happens. And when you talk about some of these very volatile issues like human growth. And we can't even talk about equity. We can't even, you talked about social moment. We can't talk about social and emotional learning. We can't talk about trauma-informed care, because those terms have become weaponized and are used against school board members across not just Wisconsin, but the country. This is an organized effort to say, well, if you're talking about that, this is really what you mean. And it's very disheartening. Obviously, we can't give up. And this isn't the first time that boards have faced, I think, public uproars, but the level of it is not like anything I've seen in my 60 years.
Well, you're fortunate because our current president practices in Appleton. So there you go. We can,
that's great. That's great.
Thank you, John. I appreciate that. And we're perfectly willing.
So we are at time. I want to thank our panelists for, first of all, just the deep devotion that all three of you have to thinking about children and their well-being and what's best for them, and of the various challenges we all face in making these environments work as best as it is possible. It's really appreciated, and thank you for taking the time to give us your insight today. So, thank you, Teresa,
Thank you.
John.
Thank you.
Thank you.
All right. With that,
Pash, you muted yourself.
thank you. It would not be a thing if someone didn't do that at least once. So anyone of you having a bingo card about where the speaker and the MC mutes themselves, there you go. Thank you. So in wrapping up now, I would like to invite Maria to kick off a last set of observations and some results to share with us, and we'll bring this all home from there.
Great. Thank you, Dr. Nazaria. Rochelle, would you be able to share the slide? So in recapping from this morning's interprofessional discussion, we mentioned that the survey link that was sent out would be compiled into word clouds. And so I'd like to start off by just sharing composition visualization of those responses. So if you go to the next slide, please. The first question, again, was what do you hope to gain from today's event? And once we compiled the words together, Rochelle, were you able to show that?
Did you send the link for them or?
Yep, it is an email. Otherwise, if you would like, I can share my screen if that's easier.
That might be easier.
Okay, not a problem. Okay. All right, let me know when you guys are able to see my screen. Are you guys able to see it now?
We can see your desktop.
Okay. How about now?
There we go.
Okay, beautiful.
Thank you.
Not a problem. Thank you guys for your patience while we got that updated. So as you can see here, the composition of that first question, and we can see common themes, big words jumping out like partnership, understanding, opportunity, happening, all very relevant, I think, as the conversation developed today. So the second question was, what do you hope children will gain from today's conversation? And we see similar themes coming through. Concepts like better health and learning and improved collaboration. Also, you know, you can kind of see in the distance words like network and advocate. So I hope that those really hold true as we keep in that central focus of improving the health for children. And our third final question was surrounding what are tangible outcomes 1 year from now that could come from today's conversation. And right in the center, we see health. And I think that's so true. We really hope to see those improved health outcomes, improved collaboration. You can see different layers: school, district, medical, child, mental. And I just think it really demonstrates the complex nature of the topic today. So moving into key findings based off of the literature review and interview of key stakeholders that I talked about earlier today, there are 6 synthesized concepts to further consider. So zooming in on that first concept is to promote a network of collaboration. And this could include support for school district decision-making and medical advisors in making the agreeable partnership. It could also include further network collaborations between public health agencies, healthcare systems, school health staff, really helping reinforce that ongoing community collaboration for health services. The next key finding and future consideration is around value for school nurses as school health leaders. This could include offering sustainable support for their roles and responsibilities in order to balance their voice on future decision-making and allocate time for the ongoing health services within the school health community. The next is support medical advisors. And this could look like skill building and clearly articulating roles and responsibilities, really just helping establish successful partnerships with school districts and promoting the effective collaboration with school nurses. Next is align resources to really promote data-driven and evidence-based decisions. One way this could be done is implementing for school districts through the integration of school nurse input on electronic records or school student information software, and really just helping ease that reference point and strengthening the use of data in helping make those health-related decisions within the district. And considering COVID-19 pandemic as an opportunity. Now, this could look like building on the collaboration efforts across agencies, reinforcing the value of school nursing services within the school district, promoting and established collaboration with medical advisors, and encouraging the use of data to make systematic and timely decisions surrounding health. And the final key point here is prioritizing school health. And really, this is a vital component of regular school district decisions. And this could include collaboration partnerships and really elevating the impactful value of health for students, for staff, and for the community. So I will pass it over to Dr. Nazvaria.
Thank you so much, Maria. You know, it's always nice when you pull information from different sources, right? That you look at literature review, you look at stakeholder interviews, and then you think about the conversations and comments and questions and debate and everything that we've heard today. And you see all the strands starting to pull together, right? There's some really strong themes here. So what I really look forward to is now what's next, right? As your slide says there, tomorrow thinking, right? What do we start working on tomorrow? It's the details, right? To say, how can we get to some areas where we say, these are some areas that are really key, really ripe for making a difference, and for making a substantial difference in the landscape of how we think about schools and health in the state of Wisconsin, and starting to move forward and think and who needs to be in those conversations. How do we do that trust building, the relationships that will let us have this be successful as to the extent possible. So as part of our follow-up evaluation that everyone will receive, you will get a summary of all these discussion points. And please stay tuned in for various collaboration and advocacy opportunities that will come up from the chapter and our partners in the upcoming months. And we will be coming and asking for your expertise, your thoughts, your ideas, your networks to say, how can we go on this journey together and really get us to a better place. I want to thank all of our speakers today for taking their time and their thought and spending that all with us to really bring this all together. To everyone who who came and listened and spent time, again, whether it's later you're hearing this on the recording or whether you were popping in and out or stayed with us the whole morning. Thank you so much. And I'd like to thank our planning team. Maria, again, all your work really deeply appreciated, really helped us all come through. Dr. Lamont, again, your expertise and your thought for in terms of school health that has been going on for so long is just incredible. Kia, for just driving the whole thing forward, all your connections with various state and non-government agencies that really have a hand in all of this. And Rochelle, for quietly making this all efficiently appear and run, moving those slides forward, which I gotta say is, I think that's a nerve-wracking job, right? You're waiting for the next slide, please. The only worst job, I think, is the teleprompter runner, which we thankfully don't have a teleprompter, but I was at a conference last week where I don't know how much anxiety the guy running the teleprompter had to go through and so on. So again, thank you, everyone. And I'm delighted to give everyone back at least 5 minutes of their day to not be in front of Zoom. Thank you again, and more to come.